our on-call nurse. They would advise and guide if there's a need in terms of anything that's going on at that time, but equally are at the end of a phone to be able to advise and guide in the middle of the night or go out and visit that family. Then there's follow-up care from our community nursing the next day, who would contact the district nurse and update them as to what has happened during the night, so that continuity of care continues. And again, that would be reciprocal in the afternoon as well. So currently we're only able to provide that in a small area, but the impact has been phenomenal in terms of not only for those families and the patient to be able to die in comfort and in peace in their own home. You know, there's the support to the family and reassurance. But equally then there's reassurance to the providers during the day, and that continuity of care. And the feedback from professionals in the area have been that they would love to see that service to be extended. I mean, that's one example when we talk about a postcode lottery. And I don't know, Bernie, if you want to add anything in terms of...
Just I would reiterate that, you know, I'm currently doing my Masters, and I'm doing a service evaluation of the service, and the feedback has been phenomenal, you know, and that's what I'm hearing time and time again, is if you could only, you know, spread it out. You know, it's you don't want somebody getting a Rolls Royce service and somebody at the end of the road because they're in a different postcode not getting that service. So, you know, we set it up because we identified the gap and it was very much needed, but we would love to be able to scale and spread it because the impact, as Bridget said, has just been phenomenal. I also would do the odd shift on the service, and when you make that phone call at night, you know, you can hear the relief. It's palpable, you know, at the end of the phone. So it really is, it's making such a difference.
And I suppose I would add that when we look at our statistics of the underlying diagnosis that patients have, hospices are well known for working with cancer diagnosis, patients with cancer diagnosis, and less well knowing from working across the piece of palliative diagnosis. So if the system was less fragmented and we had more secure funding, we would be able to offer services to all palliative patients with whatever diagnosis they had. So it would be about breaking down that hospices are for cancer patients with palliative diagnosis. We're much wider than that.
Yeah, and I mean, you talked, Fountains obviously comes up all the time at this. So 50% is what you're supposed to get. You're saying it's much less than that. Is there engagement currently going on with SPPG in relation to the funding model and funding for moving forward? Yeah, no, the
SPPG work hard in the palliative care arena. I think, you know, our view is that the 2004 circular has never been implemented in the way it was intended, and it's definitely not implemented literally. The contract we have doesn't necessarily reflect all the services that we have because the contract is out of date. So it's really important that your commissioner's contract reflects what you're actually doing on the ground. And as we say, in last year it was 35.6%. That's what SPG's contribution was, and that's net of our costs to deliver income generation. So we income generated over 3.5 million last year.
Okay, and then just finally from me, so you talked about the needs. So if this committee inquiry was producing recommendations, as we obviously will be, and one of that was able to influence an up-to-date regional strategy, you know, what are the kind of, if you were to boil down 3 key priorities that absolutely needed to be on it that would make the maximum impact, what would that be?
First, sorry.
Well, if I go first, maybe. So I think we're saying we'd like a clinical lead, and I think that's important to provide that overarching assurance and also development in the palliative care strategy. We need to seriously look at legislation. We think that should be a rights-based legislation, but it could also follow the legislative approach that they took in Ireland, where a more secure funding model secured the providers, but it also increased, by securing the providers, increased access to care. Short-term things are, let us into the Encompass system sooner rather than later. the strategy could also look at how we get early identification, because we're seeing more and more patients presenting with very late stage diagnosis, and the ability to help them live well for as long as possible is seriously compromised because of their late diagnosis. So really everything that we've talked about, everything that we have presented in our written evidence could be addressed in a strategy, and we're concerned that not producing a strategy because we don't have the identified resource to deliver the outworkings of the strategy. We don't think that is necessarily the logical order.
Yeah. I would also add the implementation of the advanced care planning and respect form and process as a big priority. It's shocking to see the amount of patients that are admitted to our hospice for end-of-life care that have never had a DNA CPR discussion, and again, there's multiple reasons for that, but that lack of early identification, and it all comes down to resources, but yeah, that would be key for me. It's the moral distress that is caused for patients either not having had it and then coming in a crisis and having to have it, or having it multiple times. It impacts patients, families and staff, and it's sitting ready to go, so that would be one of the key ones.
Okay, so I'm going to move on then. Linda? Yep, that's you. Good to go.
Thank you. And thank you for the presentation. Apologies that I'm not in the room with you. And thank you also for the day that you facilitated the visit at the Southern Area Hospice, because that was very helpful. And certainly for myself, who did work experience in the hospice over 30 years ago. And in terms of the building that you talk about, it's 65 years old, but I would say in those 30 years there have been very little changes. And that's reflective of the funding model. It would be my view that everything that you raise, which is a significant effort in itself, but it all has to go into the services, and rightly so. But if you were in a position, as they are in the South, where they're 100% funded for the services, then you would be able to invest in that building and the surroundings, because at the end of the day, these people are very often at end of life, but if they're not, they're not in the best circumstances, and the surroundings are important. The services are vital. They are what are required and needed and must have, but surroundings are important, and we know that. So I think that it is important that we do focus on that in this inquiry, and in terms of what we're asking the Minister to do. Just on the priorities, and I mean, obviously you'll know that they're probably similar to what other people in your position are telling us, but I think this is the first time I've heard anybody saying so clearly about the increase number of people getting that late diagnosis. And it's something that I've been saying for quite some time, that just, I suppose, anecdotally dealing with people in the community and families who are in that circumstance and are getting diagnoses very late on, I felt that there's something not right, that there's something happening that we're not being made fully aware of. So I suppose I would be keen, Chair, that is included in this, and that we do get something from the department around if they have any figures around that. And then just a question for the ladies, for Bridget and for Liz and Barney. Has there ever been any assessment done? I'm not suggesting this would happen, but has the department ever looked at how much it would cost them if your service was not there? Because these people will not disappear. They will need to be looked after, and I'm not just talking about the inpatients, the people who are at home as well, that you're supporting, the families that you're supporting. Has there ever been any cost analysis done, either by the department or by yourselves or by anybody, about the cost if you were not there, the cost to the health department? Do you know?
Well, the short answer, Linda, is we don't know. We know what it costs us to provide our services, and we believe that we run a very efficient organisation. So I might suggest that if those services were provided elsewhere, they would even be more expensive than it costs us to provide them. But I'm not aware of any piece of work that has been done that if we were not there, what would happen to the patients and the family members that we work with. What I would draw the committee's attention to is that there is a lot of evidence about what happens if a palliative care patient who is in distress, either from symptom management or pain control, if they end up in A&E, and we know the pressures that A&E are under, there is very clear evidence to show that that is a very poor way for that person to get care. It causes a lot of distress, it's not effective. So there's lots of evidence that would suggest that if we weren't there, some of the outcomes for the patients would not be desirable.
Yeah, I think we would be well aware of that. I think to be fair to you, we would have a real clear understanding of that.
We know from
and I can guarantee you that the cost would be significantly more if you were not delivering it. So I think that, again, everything that we've looked at in the health service would tell us that. I don't know if either of the other two ladies want to comment just.
Yeah, Linda, I think we know, even when we talked about the out of our service, we do know that we have cut costs in terms of A&E visits. We know that happens, that we have prevented a good number of those patients ending up there. I think what's also important to highlight is the human cost, the trauma, as Liz had pointed out, to families, to those people who are actively dying, and how, I mean, that's very important as well when we're looking at costs, because the fact of the experiences of the family, that again then adds to the health service cost when you have people off work, when you have people attending GPs, when you have people attending mental health services, and the services that we provide support them through that to reduce some of that. But equally then, if they do have those experiences, you don't need to be known to the hospice. If you're bereaved from a palliative illness, you can access our services. And as I've highlighted in the document, the number of people who are attending our services with complicated grief is very high.
No, I appreciate that. I suppose, Chair, it goes back to the point that we keep making in terms of, I understand the department is under significant financial pressure, but we're not talking about more money. We're talking about how the minister spends what he has and what is a good investment. So I think that we just need to make that point again.
Linda, thank you.
Thank you, Chair.
Annie?
Thank you, Chair, and thank you for the presentation. That's very enlightening. I wanted to dig into something first. I think it was yourself, Bernie, we're talking about the DNA CPRs and advanced care planning. Something we've heard again and again from the ambulance service and from a lot of other palliative care providers. It seems bizarre and mad that people either aren't having these conversations, in a timely manner, or recurrently having the same conversation again and again, which can be distressing. One of the things that you had mentioned about cost that might be involved in that, from my background's nursing, and a DNAR conversation is a conversation. So what would be the barriers to improving DNA CPR and implementing advanced care planning?
I think my understanding would be the resource involved in training, regional training for staff to carry that out, to implement the respect form and document. As a specialist palliative care workforce, we're very well qualified to have those conversations, but it's not going to sit solely with specialist palliative care. It's going to be, palliative care is everybody's business, so there's going to be significant training involved. But I suppose it's just disappointing that it's over 2 years now sitting ready to go, and patients are still being admitted to hospice, and nobody has broached that conversation. It's alarming really that that patients are coming in actively dying and nobody has had that conversation with them. It doesn't happen all the time, but we are seeing it, and it shouldn't be.
In fact, we have to have the conversation again. So it's both.
Absolutely.
Just for your knowledge, sorry to interrupt, the committee aren't waiting on the inquiry to ask about this issue. We're actively pushing this even in advance of the inquiry.
It is something that has stood out in a lot of the people who have been giving us evidence.
I think if you've been involved, I worked as a specialist palliative care nurse in the community, and was involved with active resuscitation of a patient that was palliative, walked in on a paramedic carrying out CPR, and things like that stay with you, you know. And when it affects a health professional, you know, you can't begin to think the impact that's had on a family, you know, and that's just one example. I know many people have experienced that, and it just shouldn't be happening.
You're not the only person who said exactly that.
It's fundamentally about dignity and respect.
I think the other problem is the fact is that a lot of work has actually gone in to developing the policy and the form, and yet now it's stalled. And, you know, so all that work, and now there's a gap in terms of actually getting over the line. So I think, you know, that's a major flaw in terms of being able to, when you think, like, we're looking for lots of the changes. That's one that's actually sitting there ready, and we can't get it over the line.
And the only barrier would appear to be training staff.
That would be my understanding,
But I'm not sure that's necessarily a barrier for us. It seems to be a system barrier.
Regional.
Thank you. Just a couple of other questions. Your submission and your feedback, you had said that you believe the state of palliative care in Northern Ireland at the minute is poor. What is good palliative? What does an ideal palliative care system look like? And what do we need to do to move towards that?
I may be starting and hand over to my two clinical. I was a nurse too once upon a time. So palliative care and hospice care is an ethos. There's a whole ethos, and we believe that that's the ethos that should be underpinned in a regional approach to palliative care. So that means that we look after the person who has the palliative diagnosis well through their palliative journey, helping them to live well for as long as possible and then die well. And in doing so, we are also supporting the family and their loved ones. And clinical doctors, nurses, care, that is extremely important in that type of ethos, but they're not the only members of the multidisciplinary team who are important. So it's the whole team that are important. There is a focus on the clinical side, in our view, to the detriment of looking at the situation holistically. So we would advocate that the model, the ethos, needs to be a holistic one. I'm going to hand over.
It should be a holistic approach to how we look at the person. It's the physical, it's the emotional, it's the psychosocial, it's the spiritual well-being, and all those professionals and people who come along with it and who provide that support. And I suppose that is a model that we provide within the Southern Area Hospice, both in our inpatient unit and within our community. Equally then it's about educating your community, educating your professionals, supporting them to be upskilled, to provide the support that is necessary. And again, so I think it's fundamental that we think through every element of that when we begin to look at a strategy or a regional approach. It should also take into account the urban and the rural needs of the population and how we manage that, and that may be different and in different ways, but but it should be aligned. I think
I would definitely agree. So definitely a multidisciplinary approach, because as Liz said, often symptom management, it can be pain and we're maybe tweaking medications and trying to get on top of somebody's pain, but it's total pain, and it's not until the chaplain comes in maybe and spends time and, unravels spiritual pain, that we get that symptom eased or relieved. So it's looking at the whole picture. And that it's, not just a biomedical model, that it's very much, it's the whole person holistically. A regional approach so that it's standardised education, most definitely, pre-reg education among all disciplines. And we are seeing it now with paramedics, which is brilliant. But it's alarming that, colleagues as high up as consultant level in other disciplines have such a poor understanding of palliative care. So, if health professionals don't understand what palliative care is and what we as a hospice can deliver and what services we have, what hope has the public? You're not going to identify those needs or be able to signpost somebody on if you haven't got that awareness yourself. So it's multi-pronged, but yeah.
Thank you very much.
Thank you.
Okay, I've no other members have indicated to speak. So, I mean, you talked there about the holistic approach, and that certainly was the thing that I came away from the visit just really impressed about, beyond all the other services, just was the holistic approach taken by yourselves. So, ladies, thank you very much. That has been extremely useful and informative, and we hope to do yours and all of you justice whenever we produce our inquiry report. Thank you.
Thank you
Thank you very much. Thank you. Now.
Thank you for prioritising this.
Thank you. Okay, members, so we're just moving on then to item number 6, which is briefing from the Northern and Southern Trust. It's an oral briefing again on our inquiry, access to palliative care. So can I refer members to papers tab 6, including Clerk's memo, page 38. We have responses from the Northern Trust at page 42 and consultation response from the Southern Trust at page 46. And we have also an opening statement from the Northern Trust at page 2 of our tabled papers. So, we're slightly ahead of time, which is I haven't yet said since becoming chair of the committee.
Here, yeah, Chair.
Right, okay, we'll go to item number 8 on our agenda, which is the SL1 on the Health and Social Care Pension Scheme, Amendment number 2, Regulations NI 2025. So if I can refer members to the SL1 at tab 8, which includes Clerk's memo at page 196. The SL1 itself is page 198. The Department's report to the Assembly on changes to member contributions, that's at page 240. Consultation response document is at page 250, and the draft SR is at page 285. So the Department is proposing to make a rule that will make technical and miscellaneous amendments to the pension scheme regulations. Similar regulations have been brought into force with equivalent NHS pension schemes in other jurisdictions. The various impact assessments have all concluded that no adverse impacts are anticipated. So the Department will monitor the effect of the amendments on scheme members. The rule will be subject to negative resolution procedure, and the Department hopes to introduce it as soon as possible. So can I ask members if they have any comments, or if we're content on the merits of the policy and the Department makes the SR? Content?
Yep. Okay,
thank you. We're just item number 9, Departmental Written Briefing on Maternity Review Report Implementations. Just to remind everybody, the committee had issued an email to members on Monday to advise the Department wouldn't be providing a written briefing at this time, as it was awaiting further information in the matter, so a new date for the briefing has been requested. Okay, just number 10 then, Departmental Written Briefing on the Hospital Car Parking Charges. Can I refer members to page 306 of the meeting pack, which contains the latest of the 8-week written updates on the new traffic management system at the hospital sites. Are members content to note, or to continue to note the briefing paper? Happy enough for that? Okay, so we'll go back then to our witnesses are now here. So,
Can I ask, just with that, are we due another one before the autumn? So we get one
We do another one in June.
for the
in
summer.
June, just before the break.
Yep. So can I welcome Alison Campbell-Smith, Assistant Director for Community Care within the Northern Trust, Dr. Mary Ann McCann, Palliative Care Consultant, Northern Trust, Dr. Louise McNutt, Palliative Medicine Consultant, Northern Trust, Dr. Sarah Cousins, Palliative Medicine Consultant, Southern Trust, and Dr. Gemma Ryder, Palliative Medicine Consultant within the Southern Trust. So thank you very much for coming before us and for providing evidence to our inquiry. So I'm just going to hand over to yourselves to make a brief opening statement, and then we'll take questions from members. I don't know if you have worked out. Yep. Who's taking charge? Go ahead.
Thank you, Chair, for giving us the opportunity to address the committee from the Northern Trust. I'm Louise McNutt. I'm one of the palliative medicine consultant doctors within the Northern Trust, and I work across our different settings, including in our hospice, the Macmillan unit, in the community, in people's homes, and also within our hospitals. By now, you've heard from quite a number of our colleagues from across the province, representing a range of organisations, trusts and professional bodies. You'll have begun to appreciate some of the varied ways in which palliative care is delivered in Northern Ireland, with a range of services and providers in different areas. And I'm sure you'll agree that a common factor has been the passion with which each of our colleagues has spoken. I think amongst us in palliative care, we've all experienced that head tilt and sometimes awkward look when someone inquires what you work as and you tell them that you work in palliative care. But we didn't land in these jobs by accident. They weren't the only ones left. We all care deeply about and are committed to delivering high quality palliative care, to helping people with life-limiting illnesses to live and ultimately to die well, regardless of where they are in Northern Ireland. And this is why we really welcome your inquiry with open arms. In the Northern Trust, the demand for palliative care services has never been greater. We have the highest population of any trust in the province, including the largest elderly population. This cohort is living longer with multiple comorbidities and complex needs. The Trust has the greatest number of deaths annually, with the latest figures in 2023 showing that we had almost 1,000 more deaths than any other trust, and this is proportionate to our population. Our Trust also has the broadest geographical spread in Northern Ireland, and this rurality can mean that delivering care to patients in their own homes when they need it can at times be challenging. You've heard my colleagues over the weeks explain the concepts of generalist and specialist palliative care, how generalist palliative care is delivered by non-specialist staff across nearly every healthcare setting, working alongside specialist palliative care teams who are involved with the most complex patients. In the Northern Trust, our hospice, the Macmillan unit, is at the centre of our service. It bears many similarities to the other hospices you've heard from. Our specialist palliative care multidisciplinary team, including allied health professionals, consultants, specialty doctors, nurses, a chaplain, a pharmacist and volunteers, work together to provide holistic assessment of and care to palliative patients with the most complex of needs which cannot be met in other settings. Whilst this specialist care we deliver is similar to other hospices in the province, the Macmillan unit differs in that it is run and funded by the Northern Trust. To give you some background, the unit was established after a need was identified in the early 2000s for specialist palliative care inpatient beds, or a hospice, within the Northern Trust. The build was financed by a collaboration between Macmillan Cancer Support and the Trust, as well as local fundraising initiatives, and it opened in 2012. Macmillan part-funded a number of core staff posts within the unit for several years, with the proviso that the Trust would fully fund these at the end of that period, which it has. We are immensely proud of the Macmillan unit and of the care that we provide there, and indeed we receive excellent feedback from patients and their loved ones. Just last week we welcomed Minister Nesbitt, who commended the staff on their care and on retaining a Quality Environment Award. However, our Macmillan unit is only one part of the palliative care services within the Northern Trust. In addition to funding this unit, our Trust must provide palliative care to patients wherever they may need it, be that in their own home, in a residential or nursing home, or within one of our acute or community hospitals. Given that we have an NHS hospice, we are less able to develop our wider service as we would aspire to in our hospital and community settings. Our specialist palliative care workforce is detailed in the written document submitted, so I won't repeat that in the interest of time. But this workforce needs to grow significantly in order to meet the needs of our population. One small but impactful change that we have made in recent years was to increase the specialist palliative care presence in the emergency department in Antrim Hospital. The availability of a palliative medicine consultant has enabled earlier identification of patients with unmet specialist palliative care needs. Timely assessment and senior decision making has led to a range of improved outcomes for patients. For some, admission to hospital is avoided altogether, with these patients being discharged home with a change in management. Some others are transferred directly to the Macmillan unit, which is on the same site. if specialist inpatient care is needed, and if there is bed availability. And finally, those patients who do require admission to hospital have appropriate changes to their symptom management from the outset, with ongoing input from the hospital specialist palliative care team. The presence of this consultant at the hospital's front doors has strengthened relationships with acute staff there. However, this in-person service is not available all of the time, even in ours, and is only in one of our acute hospitals. We know that we provide high quality care to many people, but we could do more with greater investment. Finally, I'm going to briefly tell you about the good, about a case where a patient benefited from collaborative working and integration between our hospital and community, generalist and specialist palliative care teams. Ideally, in palliative care, in any setting, we would receive a timely referral for a patient, allowing us to carry out a holistic assessment of the patient and to establish their physical, psychological, social and spiritual needs, and thereafter to involve the appropriate professionals in their care. However, unfortunately, it doesn't always work out that way. Time is not always on our side. As others have said, we are seeing increasing numbers of people presenting with cancer that is already advanced, or other terminal illnesses which are similarly in their latter stages. This lady, in her early 30s, presented to an acute hospital in our trust feeling unwell. Investigations revealed that she had an advanced, incurable cancer of the gallbladder and unfortunately was not fit for any oncological treatment. During her time in hospital, she was assessed by one of our hospital specialist palliative care nurses. This nurse commenced medication to control the patient's pain and referred her to the Northern Ireland Hospice Community Specialist Palliative Care Nurses, a team who are commissioned by the Trust, when she was discharged. The hospital nurse had appropriately emphasised the urgency of the referral due to concern about the patient's symptoms and her prognosis. The community team responded quickly, however the patient declined the offer of a visit. She kept both our community team and the district nursing team at arm's length, reporting that she did not require a visit. But the community team became concerned and encouraged the lady to allow a specialist nurse and myself to visit. The person we met that Wednesday morning was frail and unwell. She was deeply jaundiced and she was in pain. She was becoming less mobile by the day and unable to do many things for herself any longer. Family members were doing what they could, but they had respected her wishes not to seek further help. For this lady, you see, like many others that we meet, even the word palliative was very much a taboo subject, and perhaps by not engaging with the team sooner, she had hoped that she might keep the inevitable at bay, even for a while longer. We spent 2 hours in her home that day, trying to gently and sensitively assess her symptoms and needs and to ascertain what was most important to her. I wondered if inpatient hospice care might meet these needs within the short period of time that I feared she had left. But she was very clear. Remaining at home and attending a local football match that weekend were her priorities. She didn't make that match. But thanks to the rapid action of the district nursing team and the GP, both within and out of hours, the arrival of a much-needed hospital bed, commencement of an emergency care package and ongoing involvement from our specialist team with medication changes, this lady died comfortably in the presence of her family and in her own home. This is the kind of palliative care that we aspire to be able to deliver to everyone. But unfortunately, that is simply not always possible at present. Services aligned in this instance, but we do not, for example, have a full specialist palliative care community multidisciplinary team in any part of the Northern Trust, nor daily specialist in-person medical cover in the community, or reliable availability of care packages in all areas. And as you know, both district nursing and GP services are already stretched. This patient could equally have ended up in the emergency department or dying at home with less support or more symptoms. So we warmly welcome this inquiry and we appreciate the time given to it. We realise that the department is in a difficult position and we are aware of the financial constraints. However, palliative care services across the province must be prioritised. Each and every person deserves accessible, high quality, timely and individualised palliative and end-of-life care. To achieve this in Northern Ireland, we need development of a regional strategy and funding which are based on population need and are cognisant of local factors. We need standards around service specification which will help to define the type of services required and the workforce needed to deliver these. There should be dedicated funding for training places and pathways for all members of the multi-professional team to ensure an adequate and sustainable workforce. We also need clear and transparent commissioning of services across trusts and the charitable sector with seamless, equitable services for all. And finally, we'd like to extend an invitation to you, committee members, to visit the Northern Trust and to see our specialist unit and palliative care services. Thank you.
Okay, thank you very much. You talked about the passion that we had heard prior to you coming, so I think you've done well to ensure that continues. I mean, we have. Oh, apologies. Sorry, that's just one half. So, who's going to speak from the Southern Trust?
It's myself.
Yourself,
Thank you.
sorry,
Will not be
apologies.
offended. Will not be offended. Thank you on behalf of the Southern Trust for this opportunity. So my name is Dr. Sarah Cousins, and I'm one of the palliative medicine consultants, and I work in Craigavon Hospital. And this is my colleague, Dr. Gemma Ryder, and Gemma is the community palliative care consultant. Okay, so Gemma's actually just recently joined us from England. She's worked with us for about a year now. So she was there for about 15 years in palliative care. So if there are specific questions about comparison between Northern Ireland and England, please direct those questions to her separately. Just to highlight at the outset, we are completely NHS consultants. Okay, so we are Southern Trust employees. The multidisciplinary teams we work with are all Southern Trust employees and Southern Trust funded. So working within the NHS system, we have a slightly different focus to that I hope will be helpful for you to understand. Okay. So firstly, let me paint a picture of the Southern Trust palliative services. So the Trust provides general palliative care across the various adult specialties, including inpatients, outpatients, community services. Now, of course, some adult trust services are going to see palliative patients more frequently than others. So I'm thinking of our care of the elderly colleagues who would see patients in their last year of life and in those last days of life more frequently than others. However, I could not think of a single adult service that never was in contact with someone with palliative needs. Okay, and as an example of this, so as both the hospital and community specialist palliative care team, we were significantly involved recently in the care of a pregnant woman with palliative care needs throughout her entire pregnancy. But while we were there as the specialist palliative care team, she was also being cared for by the Craigavon obstetrics team and the inpatient midwives and the community midwives and her GP and her district nurse. So really, even teams that seem not to be providing palliative care are required to provide that general palliative care at some stage. So moving on then to our specialist palliative care services. So it's the hospital-based palliative care team that I work in. So that is a Monday to Friday, 9 to 5 service, and it's based in Craigavon and in Daisy Hill. We have 2 sites on that. So it's palliative consultant, myself, palliative nurses and a palliative pharmacist. We don't take over patients' care, but we draw in and work alongside the ward staff, the ward doctors and nurses to support that holistic care for patients who are palliative. All trusts would have this type of hospital palliative care team, as it would be called. The community is where we're slightly different. So in terms of the community specialist palliative care team, where Gemma is the consultant, this is also a Monday to Friday 9 to 5 service, and it is for the entire Southern Trust. And this is the full multidisciplinary team, and this is where we differ from other regions in Northern Ireland, because in other regions this palliative nursing service would be commissioned by the Trust to a hospice. So, for example, Northern Ireland Hospice or Foyle Hospice. But in the Southern Trust, this is all NHS Trust funded and Trust run. So to give you an idea, so we have approximately 3,000 deaths in the Southern Trust per year. And last year, in 2024, we had 1,500 referrals to our community specialist palliative care team. Okay, so there is a growth, and from 2021 until last year, that is up 33%. There is also a slight sense that this is increasing exponentially, because for the first 3 months of this year, from January to March, comparing last year to this year, we're up 13% as well. So there is this sense of an exponential increase. The increasing number of referrals has led to the Trust to having to prioritise those with greatest need. And on previous occasions, previous time, a palliative care nurse would draw alongside someone in their own home and would be with them for the duration of their journey to the finish of their life. We realised we were no longer able to provide that service, and it has moved to an episodic service. So the referral comes through, the community team go and manage an issue, a symptom, something. And if there's a period of stability, then we will withdraw and allow the district nurse and community team to continue. That is not what we want to do, but that is what has had to happen based on the numbers. Unfortunately, we're still pushed on the numbers from, as you would understand, resource level, and we are in the very sad situation where we are now looking to move to a waiting list for people requiring holistic care at home. So, as I say, this is different from different parts of Northern Ireland, but shows a really good example of that multidisciplinary team, which is trust run, trust funded, and for the entirety of the Southern Trust. So, in terms of inpatient or hospice services, unlike the Northern Trust, we do not have an NHS hospice, okay? We commission our services through the Southern Area Hospice Services, who you've just spoken to today. So we are commissioning for 12 inpatient beds. There are other services offered by Southern Area Hospice Services. They're charitably funded and they're at their discretion and they're separate. You may have noticed I talked about a Monday to Friday 9 to 5 service. So in terms of out of hours, we provide what we can. And what we can do is provide an out of hours telephone advice. It's doctor to doctor in these out of hours periods, so evenings, weekends, bank holidays, etc. So this really means that a GP or a ward doctor who has a question, who's struggling with some issue, some symptom management, phones through and gets directly to myself or Gemma or one of our colleagues and gets that specialist consultant level advice to the patient as best as we can. Okay. Again, this is actually something that the Northern Trust do as well with their consultant level telephone advice, doctor to doctor. But the other trusts, so say Western, Southeastern Trust and Belfast Trust, they commission these services from a company that's based in England. So that gives you some idea of the services that we as a trust provide, okay, and the ones we commission. I hope that's been of some use. What would I especially want to draw your attention to? Well, it would be two things really. So firstly, analysing specialist palliative care services. So the Southern Trust has been made aware of the intention by the Department of Health to commence a baseline audit of the totality of palliative services. And that would be both general palliative services and specialist palliative services. Now, we feel that to count the general palliative services is essentially to count all NHS adult services, GPs, every district nurse, every ward. And really, we feel that would be very time consuming, very laborious, and it risks losing some of the momentum that this committee has created in terms of drilling down and understanding palliative care provision. So what we would ask the committee, humbly, to reconsider would be directing the Department of Health to concentrate on specialist palliative care service and in-depth analysis of that. Okay. So as we know, there's often competition between charitable palliative healthcare providers. Essentially, the current system, if you like, pitches charities against each other for fundraising and for service provision. And an audit of the specialist palliative services would provide clarity and transparency that I think we're all looking for in terms of arrangements, funding, resources, criteria, areas that they cover, outcomes, all of these that you want to look for in depth so that we can look and find the gaps and find the areas of duplication across Northern Ireland. And this would be for NHS and for charitable specialist services. Secondly, we would really want to acknowledge the role of the community. So a quick lesson, it's known as the 95% rule. And the 95% rule is a compassionate communities public health concept. So I understand you're speaking to our compassionate communities lead in a few weeks' time. But really it says that 95% of the care for someone in their last year of life is provided by family, by friends, by the neighbours, by the local faith group, by the local GAA group, by the Bowls Club. It is provided by the community, okay? And really, in reality, a little more than 5% is provided by specialist healthcare professionals. So we want to acknowledge that proud tradition that we have in Northern Ireland and in the Southern Trust of people looking out for each other when times are difficult. Do you know, if it takes a whole village to raise a child, it takes a whole village to care for someone at the end of their life, help them complete their life and care for the family through the bereavement. And really, as specialist palliative care teams, that's what we want to do. We want to support that whole village. So much has been talked about a regional approach, and we just want to balance that slightly. So there's certainly aspects of work that could be regional, so commissioning, policies, guidelines, regional last days care plans, teaching and training packages, but death, dying and bereavement is not a regional experience. And I'm just wondering what services, if any, could be regional. Additionally, and with respect, our experience of regional services tend to be that they're mainly located in the Belfast trusts, with funding diverted from the peripheral trusts, and that is just not something that we could support. So honestly, thank you once again for all of this. I think sometimes the impression is that this is the public and these are the professionals. But we are all family members. We have all experience of death and dying and bereavement, and we are all just trying to do our best for the communities that we serve. So for your interest, thank you.
Okay, thank you, and thank you for your passion and thoughtfulness as well. That has been very useful, and at times slightly different maybe. We appreciate you all coming before us. I just want to pick up on the audit stuff, because I mean, one of the things that we as a committee have been a bit kind of trying to think of the right word here, bemused about is the lack of information that the department has about the services. So you're saying it really only needs to, for this, it really needs to do specialist services rather than general services.
Yes, I mean general services is, as I've tried to demonstrate with the example, unfortunately all service. I couldn't think of a single one. I refer to audiology, to podiatry. I really thought of a single service that wouldn't see people in that last year of life at any time. So really, I think to get the answers that this committee is that we're all looking for, it needs to be in depth with specialist, charitable and NHS to try and avoid that postcode lottery, which is what we're seeing at the moment.
Okay, thank you. And just because you pointed out Dr. Ryder's experience across the water, I think it might be useful just to get a sense from yourself, just because there's obviously a different legislative scenario in England, so it might be useful if you wanted to give us some of your experience and the differences here and the impact that has in patients, and what we could do if there's anything that we can learn.
I think really that despite the real passion that I know all of my colleagues across the province have demonstrated in palliative care, and the real internationally renowned experts that we have in Northern Ireland, like Professor Max Watson, the palliative care in Northern Ireland feels like it's stagnated somewhat compared to what I'm used to in England. In part of my job preparation for coming over here, for part of my interview preparation, I looked at the strategy from 2010, and then I was like, and was it achieved? And I read the RQIA report, and really my reading of it is that not a lot was achieved. An enormous amount of work was done. An incredible amount of man and woman hours, I think, went in to getting places, getting documents, strategies, developing things, but nothing or very little was got over the line. One of the differences for England is we are getting things over the line, and we've got clear palliative care leadership in order to do that, to push that, to keep palliative care, in the mind's eye of people making decisions. I was recently at the Palliative Care Conference, which was in Belfast, and at the plenary, at the opening speech, we heard from, the palliative care lead from England. We heard from the palliative care lead in Wales. We heard from the palliative care lead in Scotland. And then, most embarrassingly, we had to hear someone stand up and say, "I'm very sorry, we don't have a palliative care lead here in Northern Ireland." And I think there's so much passion, but it is going to waste because it is not being channeled and focused and championed by a clinical lead in Northern Ireland.
Okay. And another thing that we hear is about, how do you access information? We actually had a consultant one day and said that even he had difficulty navigating the system. So I'm not sure which of you, the Northern or Southern, had talked about a map with, the up-to-date thing of the services and how do you access that. So maybe yourselves.
We tried to make a map 2 years ago. We did make, it was a very beautiful map. I was tempted to bring today. Difficulty was within about 2 months it was out of date because a charitable organisation had changed the boundary of where they covered. So it was very quickly out of date. So on that kind of, if you can imagine, this is the Southern Trust, and we're looking at where the emergency departments are, should that be where you need to go. We were looking at where are the pharmacies, the community pharmacies that hold palliative care drugs at the weekend if you need to get a script for your loved one replenished, and where those are geographically. We thought about we don't have 24-hour district nurses, so we rely then on charitable organisations providing injectable PRN, medicines that might need to be injected for symptom benefit at the end of life. So where are they located? So who covers where? So Life and Time covered a postcode here, I think BT 34, but don't quote me on that. Southern Area Hospice Services covered was BT 15 and Newry City, and then you had Marie Curie, who was based in out of hours in Craigavon, and then also in Newry. So we tried to get this pictorially. Actually, a map is incredibly useful because you can start to see, well, that's a very long distance that somebody has to drive now, and that's very far away from those pharmacies if you need to increase the syringe driver at 3 o'clock on a Sunday afternoon. So a map is a picture speaks 1,000 words, but it required quite a bit of IT skills and regular updating.
It's something that could be looked at.
It would be wonderful if a family or relative could bring this up and say, "Oh, there's a death cafe going on in a library next week that I could be interested to go to." You could bring in a lot of those resources and connect people to the services.
And in terms of just moving to the Northern Trust, so you talked about younger people being diagnosed later. Is there a reason for that, or how do we undo that?
I think these are perhaps two separate things. I think the general population is presenting later sometimes with more advanced symptoms, or with more advanced disease, and this may have originated around COVID times when people were perhaps seeking less healthcare and isolating themselves and staying at home. And just very sadly, we see that sometimes symptoms can be vague, they can be quiet, and by the time someone seeks help, they are advanced. We also see in some of our elderly population, there may, in contrast, be some very obvious signs that something is wrong. An obvious fungating breast tumour, for example, that an elderly lady knows that she has, but she doesn't want to talk about it. She's afraid. There is taboo. She doesn't want to go forward with that, and then presents very, very late. So, yes. I don't have the figures, but we are seeing, unfortunately, a lot of younger people with cancer and dying with cancer, and certainly we're seeing that across all of our services, but on the whole people are also presenting quite late too.
Okay. Thank you. I'm just going to bring some of the other members in now. Linda? Can broadcast and bring Linda in, please? Yes, you, Linda.
Thank you, Chair, and thank you for the presentation. You actually covered the main question I have, and was the one that I'd asked the last time, trying to get an understanding of why so many younger people are presenting so late in their journey, and very often, as we're hearing, too late for treatment or for any kind of treatment that would make a significant difference. So I think, Chair, we do need to try and get some assessment, and that probably is something that we really need to get an understanding of, because tackling waiting lists and diagnosis is great, but if people are not actually coming for diagnosis or not being put on a waiting list, that's a major problem for us, and obviously for a palliative care service, or in some cases whenever we're talking about the lack of palliative care service. And I think the mapping issue, I can understand why that would be so difficult. I've seen discussing it with Trust before around mental health services and what's out there, and why a trust doesn't know everything that's in their trust area in terms of a service. So I know it can be difficult. This is something we've raised with SPPG, and I actually think they need to take it on and look at how we do this, because people do not know what service is when, how, who they turn to at each different point in their who you contact during the day, who you contact in the evening, who you contact at night, who you contact at weekends. It's impossible for a family to navigate, and this is a family who's already under significant pressure. So I do think we need to speak to SPPG about how they or the department can look at doing something around this. And you won't be able to, I don't think you will be able to get everything on something like that, but we certainly need to have the big things on it. We need to have who you contact at each different point of the day. So who you contact if your person needs drugs in the morning, is that wait till the district nurse comes. Who you contact in the evening, who you contact during the night and out of hours and at weekends, because leaving families and circumstances and people who are at the end of life in those situations is really poor. And I do think it needs to be an SPPG, because it needs to be across the board. We can't have where people right across the north don't know, or families don't know who to contact. I think that's really important. So I think those are probably the two things that, and obviously the clinical lead, which Gemma raised. It's been raised obviously in the previous presentation, and I suppose if any of you could give me an understanding of what would the clinical lead's role be? What would they do? I think in my head I have what I think their role would be, but just I suppose to get from you an understanding so that I'm right in what I'm thinking, I suppose.
I think really that a clinical lead would be someone who is able to focus their energy on getting things across the line. And there's been lots of breaks in the government in Northern Ireland, and what my experience has been that when the government gets back, then there are lots of fires to put out, a lot of crises to deal with, and so palliative care gets left, I think, to the bottom of the list, because I can see why dealing with A&E and people in trolleys, etc., and ambulance waits is at the top of someone's list. But actually, if we are going to go round and round in this cycle again, then palliative care is going to be continuously left to the very bottom of the pile. And I think that's not good enough for our dying patients and their families. And I think there's just something about being there, about being a reminder, about being a link between the passionate palliative care community and the government in Northern Ireland, and especially the Department of Health. Someone who has got power is the wrong word, but got the gravitas, the cachet, someone that is listened to when we feel that we're shouting into the void and no one is hearing us.
In the room and decisions are being made.
Thank you, Chair.
Thank you, Dan.
Yes, thank you, Chair, and apologies for being late. I was at another meeting which overran as well. So thank you for the presentations. I think it is really, really important. Can I ask, in terms of this regional audit that the department are doing, I mean, lots of us were surprised, I suppose you were surprised as well, by the fact that the department didn't really know what services were for palliative care patients across Northern Ireland. So as palliative care consultants in two very big trusts, have you been contacted by them? Have you had any, I mean, because it was told to us at the very beginning of this inquiry, and maybe we have had an update on their sort of information gathering, but maybe I've missed it. But have you been in touch with them? Have they spoken to you?
Yes, the Trust has received communication that there will be a baseline audit undertaken in the next number of months, and it's been an early warning, if you like, to say that this will be coming towards us. And I think it's been very timely, given the efforts of the committee, then that we do get that baseline. And actually, as trusts, we actually welcome having a final baseline survey done across trusts. Why it has become different is actually, whilst there are commissioning pieces that commission elements of work that do standardise across the 5 trusts, the 5 trusts always have an element of individualism as well. Yes. And if they have seen a need, which you've demonstrated today with the Southern Trust having a really robust community team, whereas our focus has for a number of years been on our hospice unit, and we're catching up in that community space. So without a strategy in Northern Ireland that defines what every trust should have as their baseline, trusts have done things differently in different places to respond to local need, to respond to the latest piece of guidance that has come out at that particular time, and the availability of funding, either commissioned through SPPG or sometimes trusts go at risk. So I think that disparity has borne out of just opportunities as time has gone on. But for us, I would actually welcome that baseline study because it gives us the knowledge.
So to
be
clear, I think we in this committee welcome it. Yeah. I think we were really surprised that the department didn't have enough data on what was actually happening across Northern Ireland in relation to an area of medicine where we are actually literally talking about the most vulnerable people we have. And I was really surprised. Could I just be really, I mean, sorry to pursue this, but I do think this is important. I mean, we were told this months and months ago at the beginning of this inquiry when the department came to the committee. So when were you contacted by the department in relation to this?
Couldn't give the exact date, but certainly in the past 4 weeks, 6 weeks, something along those lines.
So it has taken the department that long to actually write a letter to say, actually, you know, we're going to do this. I'm not asking you to comment on the department. That would be manifestly unfair. I'm just making the point that this is an issue that this committee has brought some focus to.
Yes.
And we would like that focus to remain. And it is really disappointing to know that in one of the very first meetings we had about the palliative care inquiry, the department came here and said, you know, oops, folks, we don't know what's out there. We're going to do a baseline inquiry. That's fine. And I mean, they should have had the information. That's my view of it. And I'm not asking you to comment, but it'll be good that they gather the information. It'll be even more interesting to know what they do with the information and how they share it and how they implement policy in relation to it. Sorry to go off on one, apologies. I suppose then the other thing I just maybe to pursue just a little bit, maybe with you, Dr. Cousins, you talk about you don't want the focus of this baseline inquiry to be on generalist services. And I can understand that, because then we would be saying, oh, look, aren't we doing very well? Thank you very much. But we needed to be on those very specialist. Do you want to add a little bit to that? Because I think that's maybe the first time I've heard that in the inquiry.
Let me explain it in a really practical way. So the request has come down to our colleague, who will be the one who will have to sit down and draw up a list of, well, okay, there's maternity. Okay, so maternity very infrequently has a patient who's palliative. Okay, do I count that as they provide general palliative care services, because when they required they do, but you wouldn't refer to them as palliative care services? Then they're going to have to look at all the district nurses and count them all out. Then they're going to have to look at, okay, well, there we have adult learning disabilities in the community, which do see patients with palliative needs. Now, is that 1 a year? Is that 3 a year? What is the average? Do I put that on the list or do I not? So how, in a practical sense, without any additional parameters, are you going to compare, this is the care of the elderly department with their acute care at home team, their outpatient and their inpatient services, versus something, there's going to be, unless you're going to give a parameter and say, and we would define a service providing general palliative care as someone who sees at least, 10 per year. It starts to become very, what is the value of knowing that? What is the value of knowing that a care of the elderly or a respiratory department care for patients here and there? There is no value with that in terms of there's no funding, there's no understanding of the resources. But what is useful is to know, well, we have the Southern Trust, okay, we have a multidisciplinary team. Can you just tell me exactly how many clinical nurse specialists there are in your multidisciplinary team for your head of population? Can we just work out how many consultants per head of population? Can we work out how much funding goes into that? What are your referrals? How long are you seeing patients for? And really focusing down on that, where are the gaps and where are the needs? I don't think that looking at the general numbers will be either possible, and certainly we'd need a lot more parameters to make it equal across the entire the 5 trusts, because the information given hasn't given any detail on their definitions of this audit. But it's also not going to tell us anything new. Someone has a list of all the adult services provided by the NHS in Northern Ireland. To count them again seems to me, when we want to focus on being pragmatic and doing and moving forward. So really drilling into those specialist services. What postcodes are covered by this charitable organisation? Is that fixed, or is that a changing thing? Is that an expanding service or a contracting service? How many referrals is that? How many are benefited by that service in a year period? It's the detail, and I suppose what you'd really want is a good health economist trying to work these details out with you, because this is about value for money as much as anything else, because we all want really good palliative care services, and we want to know that there's not duplication and identify those gaps so we can focus the efforts there. So does that explain why?
It does,
why
and
so
I think that
this
is something for us to think about.
Okay.
And that's the value of taking evidence from a range of different people. So we do thank you for that. I think you've also focused on the clinical lead and the need for leadership in palliative care. I think that's massively important. We had a debate this week in the Chamber on cancer waiting lists. And those are dreadful in Northern Ireland, and yet you're saying to us that there is an increase in the number of people that you are seeing in your team. Why are you seeing the increase so much at the minute, and what has happened that makes that has increased? Have we any?
Happy to. I suppose there's the demographics of the ageing population. Yeah. I think, especially in the community, when GP and district nurse teams are under pressure, specialist teams will see increases in referrals. I think that And I'm pleased to say that I think there's an increase in expectation of what the public expects in terms of good quality palliative care, and I'm delighted for that. They should be demanding excellent palliative care, and that specialist approach. If you're happy to add any more to that.
I think it was the population growth. So when we look at the figures of death, so in our trust, in the Northern Trust, over the last 10 years, they've went up by nearly 1,000, and it's the elderly population as well. So it's not just the younger people. I think there's the increase in deaths in every age group then contributes then to the increased referrals and the need for our services.
And sort of, I had a few more. We'll just ask one more question, which is around, you talked about your beautiful map for pharmacies. In the Southern Trust area, and I live in Banbridge, so I understand this area very, very well. We've had a number of pharmacies now that don't open on a Sunday, and in fact, if you live in my town, you cannot get a pharmacy now on a Sunday. Is that having an impact on the availability of drugs and of people being able to access those particular drugs that you're talking about when they need them?
Yes, definitely.
Absolutely, and I think there's a real clash here with, community pharmacies are very passionate about what they do, and a couple of weeks ago I was here at the launch of the Marie Curie Daffodil Standards for community pharmacy. And what I was hearing from my pharmacy colleagues, because I'm out and about in the community, but I'm not always standing in line in the local pharmacies, but I was getting to meet them face to face, and I'm hearing that they're just really struggling to meet sort of demand and to kind of pay the electricity bill at the end of the month. And I think that they are changing their opening hours so that they have some element of core service. But obviously that doesn't suit my patient group, because, I have seen people on a Friday and waved goodbye, and they have looked in relatively good health, and then something unexpected, something that we couldn't have planned for, occurs over the weekend, and they will end up sometimes admitted because we cannot get the medicines that we need to them across the weekend or in the middle of the night. And I think, we need those pharmacies to have the bigger opening hours, but actually can they pay their bills at the end of the month if on staff and things if they have those enhanced opening hours?
Certainly a very challenging aspect of it, very, very much indeed. Can I say thank you? I think it's really important to hear from you and to understand your perspectives in relation to that. Thank you.
Danny?
Chair, thanks again for all your contributions. Again, loads of passion, and we've seen that right across the board. We can feel that you really, really care about this service, and you really care about your patients, and that's great to see. I would fully agree with your comments about palliative care being delivered right across the services. My background's in nursing, and I've worked in respiratory care of the elderly and cardiology, and in all three of those, and I'm sure in every other speciality, palliative care is being delivered, by hospital staff that are not specialists, and certainly it provides a massive benefit for patients, and I've seen the difference that palliative care general and special has to patients' lives, and it is phenomenal. So thank you for that. A couple of questions that came up. Taboo came up, I think, twice in your contributions. The taboo subject of the example that you gave of the lady who didn't want services to be involved with her, and I think there was a second time it came up. It's something we've heard again and again, and there is a taboo around death. You'd mentioned death cafes. It was something I wasn't entirely familiar with, but just sort of as a public education piece, what could be done to try to encourage more people to talk about death, to talk about what they want in their own passing, and what they would expect. But certainly the death cafes is something I'm interested in.
So public health and palliative care is an interest of mine, and I'm sure Sharon Williams from Compassionate Communities, when she comes, will explain it a great deal better. But really the basic principle is thinking about connecting people to people, people to services, and services to other services to get a more, we talk about holistic care and palliative care, but holistic view of the community and the services linked in. So what you're really talking about is the death literacy of your population. Okay, so death literacy is really the knowledge and skill level of your population in Northern Ireland in terms of, they can be evaluated several different ways. Do they understand what the word palliative means or advanced care plan means or resource? So the understanding of words and having the skills to perhaps have these conversations with their families about their wishes, having the skills to find how to complete a will, having a sort of, dying literacy skills, if you like. And the death literacy of your population is very important, because then that dictates how people are going to engage with this issue. There are a huge number of projects that are done globally to improve your death literacy, your understanding. So, they've ranged from going into schools and schools programs, which really interestingly in Australia showed that you could, yes, improve knowledge in, sort of secondary school age children, but also it reduced the fear of death by 50%. So this is for that school age child, which I think is fascinating. There's a lot of the libraries do great work with kind of providing books about death, dying and bereavement. The death cafes is sort of a grassroots thing. It's really, healthcare shouldn't be at it or anywhere involved in it. This is for people to go to, have it's advertised as a death cafe. They come and they discuss their fears, their concerns, their experiences, what they know, the questions that they have to each other in that. So that's the community supporting each other and learning from each other. So that's another aspect. There are others. There are sort of online, dying to learn, I think is what it's called, like an online module that is for the general public to improve skills in this area. There's a lot in terms of bereavement, in terms of that. People want to do the right thing and people want to be helpful, but sometimes communities are embarrassed or don't want to say the wrong thing, but trying to say, just showing up, being there. We do have that very proud tradition in Northern Ireland of that, so encouraging that and empowering the communities to draw alongside someone who's bereaved, or someone who's, they know that their neighbour's caring for a loved one. I'm going to cut the grass for them. I'll just tell them that I'll cut the grass for them this week and I'll bring the bins in. These are the idea, the big idea, and then you can drill down into very many specific projects. It is not a one single project that is the only one you need to do. You need to do many to impact your death literacy.
I think all trusts have a lot of service improvement work in that area, and a range of different projects, working in schools, working alongside our learning disability folk, a lot of folk who have, they just need that improvement in their language. But I worked now in 5 years in palliative, and I think it's not a health issue. It needs to be an Department of Education, Department of Finance, Department of Communities, because we work with the high school or the local schools in Mid-Ulster. We work with the libraries in Ballymena. Brilliant projects that could be scaled and spread, but actually it's us knocking on the door, as health knocking on the door. It would be brilliant if all of the departmental bodies were also behind that, because we have products that would really meet different people's needs in different places. But if they came asking for it, it would be excellent. I think we can do pockets, but we can't get the skill and spread, and I think that's what would benefit the long-term population needs.
And I can see how rolling that out then, having those community conversations will address the sort of taboo aspect.
We had a play last week in Antrim, and it was a brilliant Nuala McKeever, a local talent, one-woman show, fantastic. And then as part of Dying Matters Awareness Week, we had a question and answer panel afterwards. A number of our specialist team were there, and Nuala herself spoke into it, and it was an excellent event. And the buzz afterwards, people chatting, people having those conversations, just leaving the theatre. That's exactly the type of things we want to do. Natural, very engaging, but they'll go home and talk to their relatives, they'll talk to their friends the next day.
Both of you mentioned, I think, the Northern Trust in your submission. You had mentioned that the Macmillan unit now has a waiting list. the 12-bedded unit operates a waiting list, and there's a waiting list now in the community, what you were saying. So obviously there is a growing need here as well, and that people obviously aren't getting the care timely that they needed, and they're going to have to wait for a period until it's available. How's that affecting you at the minute, and what's likely to come out of that?
In terms of hospices or specialist palliative care inpatient units, I think we have all throughout our training worked across a number of hospices in the province, and every hospice I've ever worked at has a waiting list. It's not a new thing. The referral numbers will fluctuate in a given time. Sometimes you will be more busy or in demand than others. But I think it's important to ensure that if we have a bed and there are 5 people waiting for specialist inpatient admission, that we assess what their specialist unmet need is. We would love to be able to offer our services as inpatients to each and every one of those patients, but if there is one bed, the most needy person needs to get it on that day. And I think it's fairly widespread across the different hospices that we have a transparent way to try and assess those needs, and that might be based on the patient's both physical and psychological symptoms, on their prognosis. Are they thought to be dying within short days or even hours? Might they have several months of time left? How severe are their symptoms? Where are they? Are they in a place of care? Now, that's not to say that somebody in a hospital might not be in need of our inpatient services, but someone who is on their own at home or with young children at home or other dependents may be more needy in that time. And on a daily basis, we update, so we give a score so that we're as transparent as possible based on all those parameters, and we try to admit the most needy patients in a given time. And I suppose the benefit of the integration we have both talked about within our trust, the integration of services, is that if we can't meet that inpatient need on a given day, who can? And sometimes we refer between hospices to see if there might be a vacant bed elsewhere, or otherwise, who's going out to the home today to reassess these symptoms, and what are we going to do about that? So it's communication and integration is really key. But yes, I think waiting lists across all services, community, specialist nursing services, hospices, etc., do show that unfortunately there is a high demand for specialist palliative care.
And that is challenging. You find on a Friday there's one bed and there's several phone calls or referrals coming in, and they all have needs, and you're like, which is the greatest need? And you know that you can admit one person, the other person then is going to be at home, and you're just hoping that there are services out there that will manage those symptoms at home. So it's difficult. There is always a resource implication, and I think that's why we are so passionate about trying to improve our services in community, so that not everybody needs to come into a specialist inpatient unit, but at least there's services out there that then can pick up in their homes.
Is that being recorded as part of the audit that we're talking about is of specialist services? Are we also looking at that type of recorded need? There are unmet needs there.
Yes. It might get recorded because we keep a record of every referral that comes in, so there'll be a length of time from referral to admission, say, or do you keep a record then of, say, patients who don't get admitted? Did they die before the bed was offered, or were they admitted elsewhere? So some of that data might be available.
Because obviously if you're recording the side of specialist practice that is available, but you're also having a look at the need and the trend and the growth, as you're saying. But obviously that would be part of what we would need to know about. No problem. That's all my questions. Thank you.
Could I just say about the community though, because I have worked in palliative care since 2010, and I have worked in many community teams, and we have never had to think about starting a waiting list before, but I've had a 33% increase in patients referred to the service since 2021. I have about 9 whole-time equivalent nurses covering the entirety of the Southern Trust, and that we have not had any more resource, we've not had any more nurses, and so the jam is getting spread thinner and thinner and thinner. So we haven't quite started a waiting list, but it is just in front of us. We don't want to have to do that because it feels like we're really not meeting the needs of our patients. But equally, how thin can I spread the nursing team across the large area of the Southern Trust?
And as we're talking about the professed deaths by 2040, I think the forecast deaths by 2040 are huge increase in numbers, so the service will get thinner and thinner unless we change it.
Absolutely.
No problem. Thank you.
I think another important related element that would be vital to record is the complexity of the patient and measures of complexity. And if you're talking, for example, about district nursing time, a district nursing contact with a patient with diabetes where they go in and administer their insulin several times a day, that is vital for that patient. I'm not disputing that, but a district nursing contact with a patient of ours, for example, contact, could be very different and will fluctuate day on day. So they may go in, so if a patient is having a syringe driver administered in the community, you'll know this well, so a syringe driver is a 24-hour mode of delivering medications subcutaneously for, and we have patients who are on syringe drivers for a wide variety of reasons. It may be because they can't swallow so well and they can't reliably take oral medication. It may be because they are less conscious towards the end of their life. So so in the community, district nurses go into their homes on a daily basis to replenish their syringe driver and fill up the syringe essentially with the medication that will then be delivered over the following 24 hours. They may go in and the patient could have their symptoms well controlled, and it is a relatively straightforward exercise of changing the medication, checking that everything is okay and leaving. But they may go in and that patient could be a lot less well from the previous day. And that opens a whole can of worms. The patient may have symptoms which need extra subcutaneous medications there and then that will act more quickly. But if the patient is less well, what do they want in that instance? Have they discussed that with anyone? And this is where respect that you've spoken about at length previously will come in, for example. Is there a loved one with them who can communicate and engage in this conversation? Does the GP or the district nurse know the answer to this? Does the patient need a set of observations? Would they want admitted to hospital to see if there could be any reversibility of their condition that had made them deteriorate on that day? So a district nursing contact for one of our palliative patients in the community can be a very varied in length, and it can change drastically for one patient from one day or 1 week to the next. And I think a record of that for both generalist and specialist teams is important. Complexity is really key.
Thank you, ladies. That again has been very, very useful and informative, so we really appreciate you giving up your time to come before us. Okay, and as I said to everybody, we thank you very much for the work that you do in this sphere and also for coming before us and giving evidence, and we hope that our inquiry does all the work that you do justice.
Thank you very much
for having us. Thank you.
Okay, members, just in terms of the evidence we've heard, it might be worth writing to the department about the audit, just to ask what the parameters are within the audit and if we can get a time frame for it as well, if people are happy with that.
Yes.
Okay.
That was very useful.
Absolutely. Absolutely. Okay, so next is item number 7, Departmental Briefing, 6-monthly update on workforce. Can I refer members to our papers, tab 7. We've got our progress report on the Health and Social Care Workforce Strategy 2026, that's page 55. November 2024 update is at page 131. We've got the May 2024 update. We've also a BBC News report from April 2025 on trainee doctors, correspondence from between the BMA and the Ministers at page 184, and a copy of the Royal College of Psychiatrists Policy Strategy Briefing at page 189. We've also got a departmental briefing paper at page 12 of our table papers. So, just checking our witnesses are. And Shaw.
Yeah, they are. Yeah.
Okay, so I'm just going to welcome Phil Rogers, Director of Workforce Policy, Department of Health, Peter Barber, Head of Workforce Policy Development, Department of Health, Stephen Galway, Head of WPD Business Support Unit, Department of Health, Rodney Redmond, Head of Workforce Strategy, Department of Health, and Catherine Ferguson, Head of Pay and Employment Unit within the Department of Health. So you're all very welcome.
Thank you.
Going to hand over to yourselves just for a brief opening statement, and then we're going to take questions from members.
Okay, thanks, Chair. Not going to say a huge amount by way of opening statement. I think we a paper would have come up last night, so hopefully you've had a chance. Apologies if it's a bit short notice. Just really, I suppose this is a sort of one of our 6 monthly updates, if you like, to the committee. I appreciate this is the first time I've met you. So the paper just really highlights, I suppose, some progress we've made on some of the key workforce issues that the department's facing. If I could just maybe highlight 3 or 4,
yep.
And then we're happy to go into questions. So obviously, one of the key achievements over the last 6 months is we've managed to close off either the industrial action or the threatened industrial action around pay for 24-25. All those pay awards have now been implemented. I think the only one outstanding in terms of people actually receiving their back pay and their money is with the resident doctors, and they should have that by the end of next month. I suppose that the other sort of important thing to highlight then around workforce strategy, we've been making good progress working with colleagues across HSC, with our trade union colleagues, etc., on our workforce strategy action plan for the next 3 years, and we've highlighted a few of the sort of the key issues which will be appearing in the next action plan. Our objective is to get that published within the next few weeks. So again, making some good progress, I say, working collaboratively across the system to identify the actions in that. Medical and Dental Locum Project, we've made some good progress in terms of establishing the various work streams needed to drive that project forward. Obviously, one of the sort of the major challenges facing the service at the minute is our use of medical and dental locums, so real ministerial priority, and we've made some good progress in terms of putting the structures in place, I suppose, to allow us to deliver that project. It's really quite complex, and we could probably spend an entire session just on that one thing, but we're making some progress there. And then the other thing, I suppose, just to highlight, is relatively hot off the press, is our commissioning plan for 25-26. We published yesterday our plan for numbers for the year ahead for 25, so for students, undergrads, and indeed specialty medical training, beginning in the late summer, autumn, August, September time. I suppose the key highlight there is we've managed to commission over 500 AHP places, so that's an increase in 100 from last year's commissioning plan. We've also small increases in terms of both social work and nursing, and some good progress in terms of medical speciality places. So we have increased the number of foundation places, and there will be a foundation place available on NIMDA's foundation programme for every graduate from Queen's and UU for 25-26. We've also made some progress in terms of our recruitment to psychiatry, recognising the challenges around the mental health strategy. So we've taken some measures to boost the whole time equivalents that we'll be recruiting to the core psychiatry programme. And there's a couple of other little things in there that are maybe worth picking up as well, and we'll probably get into the conversation sort of trying a new and innovative approach around apprenticeships. We're piloting something hopefully starting later in the year in diagnostic radiography, and that's working with the trusts to try and sort of introduce a new pathway, if you like, into HSC employment. So again, we've made some progress, and the minister's agreed some funding that can go towards that next year as well. So there, I suppose, some of the key highlights. So there's more detail in the paper, and then happy to take any questions, and we can hopefully give a bit more detail even beyond what's in the paper, if that's useful for members.
The National Insurance Employers contributions, if you want to maybe address the impact of that.
Well, I think the Minister made an announcement he's providing funding towards that. So it sits out without our responsibilities. That's our finance colleagues look after all of that. So I can't say much more than the Minister's made that commitment, and as I understand, he's found the money to do that.
Okay. I mean, you talked about the hot off the press announcement. That was timely and I suppose welcome in terms of the allied health professional, the additional places. So, I mean, obviously, all of this is about providing a better service and patient outcomes and all of this. So, I mean, the Minister has a priority of executive priority of reducing waiting lists. So maybe if you can talk about the work, I mean, because you can invest money, but you need staff, you need a workforce to be able to do that as well. Any issues with regard to the investment of this additional money, workforce issues?
Well, I suppose in terms of what was announced yesterday around commissioning, obviously you won't see those additional allied health professionals come out into the service for another 3 years. That's their undergraduate provisions. But I suppose one of the things in terms of recognising that addressing the elective care, for example, which is the executive commitment, the challenges there is a longer term priority, and AHPs can make a important contribution to addressing elective care waiting lists. So I think that there's an element of that investment will support the sort of the longer term. The longer term commitment and priority that's being put around elective care. Equally, the foundation places, that's future speciality doctors. They'll be going in and doing their foundation programme for a couple of years, but that will be future doctors that we'll hopefully see coming out in a couple of years' time. So I suppose that's as a general principle when we're making decisions about whether it's undergraduate professions, whether it's nursing, whether it's AHPs, whether it's social work or medical speciality training, we're making decisions based on what are the priorities for the service, and as you rightly highlight, elective care and driving down the elective waiting list is one of those key priorities.
I would add that I think the focus on growing the workforce supply into allied health professions is to enable down the line, as people qualify, release of really more experienced professionals into advanced practice roles, which, for example, first contact, physiotherapy, whatever, in primary care, and other aspects of transformation, service transformation, which, as you know, the Minister has been leading on. So we see that very much. That's one of the reasons why we're quite pleased to have been able to get this result this year.
And I mean, obviously, people who come here from other places play a vital role within our economy, but particularly within our healthcare sector. We've just, I mean, even on your own workforce strategy, it's commits to exploring opportunities to recruit health and social care professionals from other jurisdictions. I'm just wondering, the announcement from the British Labour government the other day, is that going to have, how is that going to impact that strategy and our workforce issues here?
Yeah, so a couple of aspects just in terms of responding to that. In terms of the immigration white paper, we're working through what those implications will be. I think our initial thought is the main impact will be around the social care, domiciliary care type workforce. As I say, we need to work through. It's only just been published. For most of our healthcare professions are graduate professions, and they don't seem to be caught up in the in some of the additional requirements, some of the additional hurdles, I suppose you would say, that will be put on people coming in. We have seen, and I suppose on the flip side, we have seen a bit of a reduction in demand for, this is from the trusts, for international recruits in nursing. So I think we're only taking about 25 to 50 maybe this year in terms of international recruits in nursing.
Focusing on
the trusts
mental health.
And particular focus on mental health nursing. I think trusts are confident that the supply coming through local supply coming through our universities is addressing most of their concerns. What we have committed to within the strategy is to explore whether we could, because we have this regional project that has a budget attached to it for international recruitment, that whether we could expand that beyond nursing. It's very much been focused at nursing at the minute, so we're exploring that with BSO and with the trust to see whether perhaps some of the allied health professions again might be amenable to a recruitment, an international recruitment project. So again, I think that's something that we'll continue to explore with trusts and BSO. But certainly, coming back to the immigration white paper, the social care workforce, because most of it sits outside of health and social care. It's not the direct responsibility of our directorate. It sits with our social care colleagues. So we work with them, I suppose, in terms of trying to understand what the implications will be from that white paper. And we had a briefing yesterday with the Home Office in terms of what they're getting. And I know then the Executive Office, TO, are coordinating an all of government response to that paper, because obviously it affects more than just the health and social care sector.
Okay, going to just move to other members. Colin.
Thank you, thank you very much, Sharon. Thank you for the presentation. Just a couple of very quick questions. Just one is, given that it's a strategy up until 2026, have you got any flavour just of how many of the various objectives that you're currently on track for delivering, and is there any of them that you think that at this stage it might look like you might be a bit short on?
So the strategy is until 2026, and I think what we will be doing is rolling over those objectives. If you think back, COVID took up a number of years of delivery on that strategy. In terms of broad objectives, I think we're moving in the right direction on almost all of them, and our third action plan will have a detailed number of actions which we hope to deliver over the next 3 years. So effectively pushing the sort of the close date of the strategy out to 2028. Like anything, there are areas where we're making progress, but there's always more that we could be doing. So if we think about commissioning, for example, we know we still need, although we've managed to increase our commissioning numbers over the lifetime of the strategy, and yesterday's announcement was another sort of big boost around the AHP side of things, we know we're still short. We know we still need to do more in that space. So I think it's one of those. It's a bit like painting the fourth bridge. Is not the analogy we use, where it's never ending. Once you get to the end, you've got to go back and start again. And it's kind of a bit like that with our workforce strategy. Our aims and objectives are, we need to do more in terms of recruitment. We need to do more in terms of retention, and we need to do more about the health and well-being of our staff. We're making good progress across all of those issues, but there will always be more to do. So I'm not sure if that quite answers your question, Colin, but
I think we're close to a better analogy being that was a political answer, as it didn't answer the actual question. But I think we get the general direction that you're basically saying it's not an end date by 2026. It's about then you review at that stage and move forward. But I don't think we should see not attaining a target or an objective as in no way a failure. I think it just means that it maybe means that more resource or more attention needs to be given to it. But given that it's workforce, I think that is something that we should accept and say, right, we didn't reach that target, here's why we think it, and this is what we can do going forward. But I appreciate the answer to that. Just in terms of the question that the chair asked, maybe just to move a little bit further with that, will we definitely be able to quantify the numbers of people that we rely upon? Because I think there is a fear that we might, in this immigration battle that some insist upon having, we may end up throwing the baby out with the bathwater and end up disbarring people from coming here that are actually carrying out very valuable work in our social care sector. And that once we move them out, we're suddenly not going to have people to do the jobs that we desperately need done. So as part of that work that you mentioned, where there's going to be an all government and all executive response to that, will it include the actual numbers of people that are employed in the various sectors so that we know how many we might be short should an extreme version of this policy be implemented? And then we can say to the public, do you want X amount of thousand less people working in your sector, or no, there'll only be a couple of dozen that will be missing? Will we be able to get a quantification of that?
Well, certainly in terms of health and social care. Now it'll be tricky perhaps in social care because it is sort of that, a lot of people are working in the independent sector there. They're not directly employed by HSC, but certainly we should be able to quantify the numbers of internationally educated graduates or international staff who are working within our system. So we should be able to quantify that. Whether that can be repeated across other sectors, I can't speak to, but certainly in our perspective, we should be able to quantify what the risks, I suppose we would say, would be in terms of health and social care.
I think it would be useful maybe if you could feed back to the other sectors, but within the department about doing that, because I do think of areas in my own constituency, which I referenced the other day in terms of fishing, where people went down for this hardline, immigration policy, and it's resulted in a sector that's now finding it exceptionally difficult to survive because it's struggling to attract people into it. And really, I think when it comes to health and social care, we can't afford that to happen. But thank you for your answers. I appreciate that. And thank you, Chair, for letting me in. Thank you.
Noah?
Thank you. Thank you for the briefing document here. On the kind of update on workforce, there's a couple of issues that I just have to ask about with regards to a number of different workforce. Firstly, I think it's important to acknowledge the increase in the speech and language positions at Queen's University, Ulster University, I'm not sure which one.
Ulster University.
Pardon?
It would be Ulster.
At Ulster University.
Yeah.
Yes, I think it's important to acknowledge that. We have had engagement from the Royal College of Speech and Language Therapists, and we are aware of the difficulties in that area in kind of fulfilling posts because there simply aren't enough coming through. So I think that is positive. With regards to social work as well, we are continuing to hear in our engagement across the Trust about vacancies and gaps in our social work teams. But when can we see a kind of positive outcome and a trajectory that's going up with regards to not just vacancies but actually met need? I think I asked actually the question the last time you were here about the assessment of the need of social workers rather than the assessment of the vacancies, because before we have had the Union in explaining that actually just because there's vacancies doesn't mean that's all that we actually need. When can we actually see that trajectory start to increase positively for fulfilling vacancies but actually similar akin to the speech and language placements?
Okay, so a couple of points just on the back of that. I think if we look at the macro picture in terms of numbers, in terms of numbers of people employed by health and social care, that is continuing to rise. And I think when we look over the lifetime of our strategy, there's been big increases. And Rodney kindly passes me a little sheet there. So if we look at social services, which would include social workers, from March 2018 to December 24, we've increased by about 20%. Now, as I think as I said last time, that does not mean that there will not be either services or teams within services or particular locations which are experiencing real challenges and real problems. But at a macro level, that shows us that we're making moves in the right direction. We did, and we are committed to doing a big piece of work which better measures our true vacancy rates, which I think is the second part of your question that you're asking. And that's with our statisticians at the minute and working with the trusts.
Are you working with the British Association of Social Workers? Are you working with those as well? Because I know that they have completed some work, so it might be worthwhile actually engaging.
We could certainly link in with them and link in with them through the well, I suppose any of those kind of professional sort of representative bodies. I think it's not we're focusing on social work, but obviously this is a
standard thing we engage with all of them.
So I think that is a complex piece of work. It sounds quite simple to say, we're looking at vacancy numbers. Trusts tell us what your true vacancy is. What are you commissioned to deliver, and what numbers do you actually have directly employed? As ever with statistics, it's not quite as straightforward as that is what we've found. So we're continuing to sort of our statisticians are continuing to work with their colleagues in trust, both in finance and in the HR side of things, to try and really get to grips with what a true vacancy number is. And as soon as we have sort of a better measure or a better number, we'll bring that to the committee and share that. But picking up your point, certainly we will engage with a range of professional bodies to try and understand, because they universally the Royal Colleges, organisations like Baswell, they will do surveys of members. They will have good information as well that might be useful for us.
I think one of the issues for us is kind of seeing, well, for the public, not just us, is seeing the turning point. And it is hard to see the turning point, and proper planning is important, proper data is important, but I think the action as well. So I guess that's why, kind of to start with the positive about the increase in the number of places for the speech and language therapists, but also that it's likely to be needed across many other sectors, I'm sure, within the health service. I also want to ask on another matter, and perhaps it's not your role today, but the GP contracts is a workforce issue. I mean, GPs are a crucial part of the health and social care workforce. So are you involved in the GP negotiations?
No, we don't get involved. That's our primary care colleagues lead on that. Obviously, they're independent. GPs are independent contractors, so it's a contractual relationship there. So in WPD, no. Well, I'm glad to say we don't get involved in that. So.
Well, given that 99% of them voted to reject the offer, and they are now talking about what moving forward, what can they do in terms of any potential strike action if that's there. What kind of impact will this have with regards to the other areas of workforce where they're trying to roll out any multidisciplinary teams, for example? Because if we don't have a fully functioning GPs, then you wouldn't be able to actually roll out multidisciplinary teams, because if there's no GP practices that is able to actually function, how can we go in and set up? Will it have a knock-on impact? Are you assessing that?
Well, again, that would be our primary care colleagues that would be principally responsible for that area of HSC. But I think you're absolutely right. As a general rule, if there's disruption, if there's action, industrial action, whatever it happens to be in one part of the system, that has implications across the rest of HSC. And the Minister's been very clear about his focus on, as he calls it, shift left, about trying to do more in primary care. And MDTs is one of the examples of rolling multidisciplinary teams out across primary care settings. If there's dispute, if there's action, that will make that more difficult, no doubt.
Okay. In particular, which I think are distinct from the social work workforce, whilst they're part of it, they have a very unique role. As a member of the policing board too, we often hear that it's police that are actually waiting at A&E to actually wait on an approved social worker and the GP arriving, and more often than not, it's the approved social workers that they're waiting on to come down and to assess an individual. We're told the issue is there's just not enough. There's just not enough that comes. And one example is last week, in which a young child under the age of 18 had already been signed off by the GP, and it was needed, the form 3 was needed to be signed by the social worker, and the wait was well into 9 p.m. at night at school. This individual had to wait, and that is a real knock-on impact on the school staff, on the family, on the young person. Has there anything been done in the department with regards to the workforce for approved social workers, given the Minister's priority of mental health before he was a minister and coming into the post? He said that mental health was a priority for him.
Yeah, so I suppose what you're describing is probably one of those examples of areas where, I said, while our headline and macro numbers are all moving in the right direction and our workforce is growing across the different professions, that there will always be examples of difficulties, whether it's in a particular service or whatever. In terms of social work, so as part of our commissioning plan this year, obviously we're increasing the number of social workers going in, at undergraduate social workers going in. There's also a Band 5 role, which might be the one you're describing. It's an ASW role, and I'm not sure if the A is approved or it's associate or I can't remember. Approved, it is. Okay, so there has, and the Minister has taken a decision to put further investment into that. Again, now that sits within the Office of the Chief Social Worker in terms of what that will look like. So I'm not entirely over the detail, but I know there has been a decision taken to put further investment into ASW roles and into those Band 5 roles.
So that could be soon. That could be.
Yeah, that would be reasonably soon, I think. Yeah,
okay.
Yeah.
Okay, thank you.
Linda.
Thank you, Chair. And following on just from some of the previous questions, specifically in relation to the previous question by Nuala around social work staff. But I mean, this is not just simply an issue within social work, it's also an issue that the Royal College of Nursing has raised around the difference between vacancies, as in what has been advertised to recruit, and the number of nurses actually needed in order to run the service, in order to staff our wards and to staff our hospitals and our EDs. And I think, and I get what you're saying about it's not straightforward, and it's not straightforward, but sometimes I think we make it more complicated than it needs to be, because the professionals, the people on the ground are telling us what they need. And why are we not listening? Why is the department not listening to them? I mean, these people aren't making these numbers up in their heads. They're not, you know, RCN and the people who feed into that and work within it have the highest of integrity. You know, they have the highest of regard among their peers. I don't know why we are not listening to them.
I suppose what I would say is I think we are, and we're trying to invest when we're thinking about our workforce and focusing in on our commissioning plan and how many places we're going to commission. We have managed to increase nursing, albeit by a small amount this year. So we'll be investing in 1,065 undergraduate nursing places this year. That's an increase from last year, albeit hold my hand up, a small increase. We'd like to go further if we could, but unfortunately our financial constraints are such that we couldn't go any further than that this year. So I suppose we know there are demands and that there is need identified across the system, across professions, and what we've tried to do with a small amount of money that we've been able to sort of identify, we've tried to put it, we've tried to both spread it, but also put it towards the priorities. And the priority this year was elective care and AHPs. So.
We've also will be adjusting our focus within that commissioning plan this year for pre-reg nursing onto mental health as well, to grow that field of practice. Just picking up members' comment earlier regarding the Minister's focus on mental health strategy. So that's to grow that workforce, the mental health field of practice. And I can also say the point you make, we do recognise when it comes to the whole strategic workforce planning, increasingly the department is looking at programmes of care approach, looking at the entirety of the care pathway and looking at all the professions that are supporting that. So that, for example, means we don't look at surgeons without looking at theatre nurses and others to support. Then that can extend right across all other aspects. So like all these things we were touching earlier, perhaps in terms of the questions about the strategy, this is an organic, progressive process, and clearly we do work closely with all parties, including RCN, in establishing just what is the understanding of the complexity of issues, and appreciate there are a big range of issues here, but we don't stand still on it.
Okay. Can I also ask then, in relation to the nursing staff, why nurses are stuck at Band 5 while similar professions are progressing to 6?
So I think that is, well, it's the nursing workforce is principally a Band 5 profession. There are a large number of Band 6s as well. There are some, I suppose, arrangements under the Agenda for Change, contractual arrangements which, so for example, I think it's midwives come in and do a year at 5 and go to 6. Social workers are Band 6 roles. But there are a number of Band 6 nurses, a significant number. I would suggest maybe not as many proportionally locally as there are in other parts of the UK. And I think that's something that is is worth exploring in terms of our colleagues in HSC. But they're not, certainly I wouldn't say that nurses are stuck at band 5. I think there's opportunities certainly to progress in your career at 6 and indeed beyond in the advanced practice roles at 7 and higher, band 7 and higher. We would always encourage trusts, I suppose, to create posts based on what the need of that particular service is, and that may well require a greater number of band or a greater proportion of band 6s and more band 7 advanced nurse practitioner roles. As Peter says, when we're looking at our strategic workforce reviews, and we're just about to start a workforce review in terms of stroke services, we will be doing that. We do this in the round where we're looking at all of the roles and all of the professions and what services needed, or what professions, what roles, what posts are needed to deliver a service. Deliver the best possible service. So that means looking at the number of doctors we need and what doctors, but it also means looking at other professions and indeed looking at what professions, those advanced practice roles, so whether that's, as I say, nursing roles or AHP roles or advanced social work roles.
So Phil, you may not say nurses are stuck at band 6, but I mean they've produced a report out this week which I think they've submitted to yourselves and the Minister, Pathway to Progression, and they seem to be saying in their own words that over half of them are stuck at band 6 despite similar others, midwifery, paramedic, social work, being able to automatically progress to. So it is a major issue if we're talking about workforce problems and pathway to progression and allowing people to come into nursing.
I think that's we would always encourage employers and trusts to create the right posts for delivering a service, and that may well require, when trusts look at a particular service, more band 6 nurses as opposed to band 5 nurses, more advanced practice roles at band 7 and beyond, and certainly I think where that's justifiable, there's no problem with that. As I say, when we look at our numbers and the proportions that we have working at band 5 and working at band 6 compared to other parts of the UK, I think we do see that we are, I suppose, overrepresented at band 5 and underrepresented at band 6. So I think we need to understand why that is, and trusts need to understand why that is. Are we designing our service differently that requires a band 5 nurse as opposed to a band 6 nurse, etc., etc. So there's certainly something to be explored and looked at there.
Sorry, Linda, I interrupted you there if you weren't finished.
Unmuted. I need unmuted.
Oh, go ahead.
Okay, that was my fault. I think I hit the mute button, so apologies. No problem, Chair. It was a very welcome intervention. So I'm going to say again, if you want to understand why we're underrepresented at band 6 and overrepresented at band 5, speak to the people that produce the report. Speak to RCN, speak to the nurses, speak to the staff. They will tell you why. An awful lot of them feel very undervalued, and we've talked about recruitment. Recruitment is only one part of this. Retention is every bit, if not more important, because there is no point in investing everything we have into recruitment and ensuring that we get people to go to university, to work really hard, to train them, to put all that resource and investment into people, to not show them that they are valued and make them want to stay in our service. And that's as big a problem as the recruitment issue. In fact, I would suggest it's a bigger problem right now. Nurses are retiring at much younger ages than they would have in years gone by. There's good reason for that. They are burnt out and they feel undervalued. So I think that we really need to seriously look at that and address it. And I would listen to the people who do the job, because they are the ones that will be able to tell us the answers and give us all the solutions.
Thank you, Linda.
More of a comment. Thank you, Chair.
Okay, Diane.
Thank you, Chair. I just noticed that in your briefing here that you gave an overview of the workforce in HSC. And to be fair, there are significant increases in the workforce across all areas of HSC. But the problem is that we don't automatically see a better service in many areas. So I was really interested in the fact that you recruited almost as many administration and clerical people as you did nurses. Yeah.
Mm-hmm. Yeah.
Which is, I mean, at a time when we should be focusing our attention on services, we're actually increasing and expanding the bureaucracy around HSC. And I note from questions and answers that have been given that actually we've now more people working in the department, even with the abolition of the Health and Social Care Board, than we had before it was abolished. So we're increasing constantly the level of administration within both the department and HSC. I'd just like your thoughts on that. Can I also take you to, I mean, it is good again that in medical and dental, there's a 24% increase from 2018, but can you outline the reasons why there is a decrease in nursing and midwifery support, and what you're doing to look at that, given the reports that we've had recently, which has highlighted severe problems within that service and within the workforce. So I think that it would be good to understand what that is. And I suppose the other thing, I was looking at some figures for GP training places. And if you could clarify for me the number of GP training places that are offered to GPs, or that are offered to people outside of Northern Ireland, and how many of those people actually stay in Northern Ireland to become GPs within the community. And I think, again, it's an interesting, because we have a workforce crisis with GPs, both retaining them and so on. And I think it's really important that when we are commissioning places, that we're looking at it quite smartly in many ways, and as to how we actually do that. But I'd really be interested in to understand the decrease in the nursing and midwifery support issue.
So picking up that point first, you're absolutely right. That's the area which you've rightly identified, which we've identified as the sort of the key macro level challenge in terms of nursing and midwifery support. So they will be kind of band 3, band 4 roles, sort of nursing, social care maybe. I don't know if that includes domiciliary care or not, Ronnie, but it's those kind of lower banding roles that are supporting our nurses, our registered workforce. So I think the major and significant challenge there is probably one of, well, it's probably a mix of recruitment and retention, and I suspect it might be more of a recruitment issue in that space. Where another
is that an issue then? Sorry to interrupt. Is that an issue? Because I noticed that in the Minister's press release he talked about apprenticeships and he talked about additional training. Is that an area where that would be appropriate?
It could be, although I think if you were looking at that particular area and we're thinking about, that's kind of our source for apprenticeships. It's those band 3, band 4 roles that then you would then turn into a nurse apprentice at band 6 or band 5. So there could be an element of that, people moving on, I suppose, to other roles. It could be an issue around, how attractive are those posts when compared to what the other, if you think about the wider labour market, what the other options might be. So I think what we have committed to within our strategy is to try and understand a little bit more around retention and develop retention frameworks for all of our professions. But equally, I think in this area, there's probably we need a deep dive to understand what's driving that, what's behind that in terms of the numbers. I think if we go back to the first question on admin and clerical, and there has been an increase.
Fairly significant increase, almost by a fifth.
Yeah,
we've increased the number.
Yeah, and I suppose it's like anything that's I know and I can say this as a civil servant, but we often get a bad press as the pen pushers and all that.
So do we. So it's
but I think oftentimes that those managers, those service managers, those people who are taking decisions about how services are organised, that there is a need for them. I think and they play an important role in terms of driving service delivery.
What is driving that almost a fifth increase in clerical and administration in the health service? What is driving that? And do you understand what is driving that, other than saying, I need them? I mean, have we a baseline for how we work that out?
Well, we can certainly have more of a deep dive into that, but if at a very simple way, and the area that we work most closely with in NHSC would obviously be on the HR, OD side of things, the human resource side of things. If you're employing more people, you're going to need more HR professionals to service that growing workforce, that professional workforce. So I think there's always an element of that. It's not even in
proportion, Phil. It's not even in proportion. I mean, do we need almost a fifth more people to actually monitor almost, nursing and midwifery has only increased by 16.6%, but administration and clerical has increased by 18.9%.
I think our latest figures were actually they're pretty close to nursing and midwifery is up by about 19%, the same as admin and clerical. But as I say, I think certainly we can take a deep dive and see where those, breaking down that admin and clerical and seeing where those where that growth is occurring. But
it is really. I'm labouring the point because it is important that in a budget that is overstretched, that we're actually directing resources to frontline services, and that's why I'm labouring the point. That's just literally where I think it needs to go. And if you constantly say, I'm just going to grow the administration of it all, without really giving us any reason why you're growing the administration of it, I don't understand from the conversation today why that is the case. But we're continuously growing administration almost at the same rate as we're growing the medical workforce, and we need to understand, and I'd really like to see so that we understand that precious resources are actually going to be directed to frontline services.
Well, we can certainly, these are the HSC figures. So these are the figures that capture who the trusts are employing. So it's their decisions about how they organise their services and how they utilise their resources. And certainly we can do a dive to try and understand where those admin and clerical and what the rationale and the reason for that increase has been.
Could I come on the GP point?
Yes.
Because you're right to say. But I know because you've mentioned before about the concerns about people's constituents' experience of primary care, and obviously the department has a clear focus on growing the workforce, the GP workforce, right the way through from what we're doing at universities and changing the curriculum there, encouraging more people to have experience in clinical practice and education within GP environments. And we have grown the programme very considerably, the one that's provided through NIMDA for the postgrads. So increased it, practically doubling it over the last 5-6 years. In the last 2 or 3 years, changes in the at home office level in terms of access to programmes in the UK. And obviously medicine is a very highly mobile area. Careers and education in the UK are extremely desired worldwide. So for that reason there have been, and GP recruitment is operated nationally. It's not run locally in Northern Ireland for practical reasons, say in terms of scale and capability and value for money. But in the last couple of years, there have been more people, I guess, against this general trend, within this general trend, coming to access the GP programme in Northern Ireland. And obviously, we welcome them, and I know the health and social care system embraces all people who join us. But we recognise there's certain challenges people coming from the systems outside. So we have a particular initiative within NIMDRA to welcome those who are new to Northern Ireland to deal with all the social and educational and other aspects, also find out what it means to work here. But more importantly, I think when it comes to general practice, it is about setting down roots within that, first of all, general practice itself, but also within areas, because that's very often how it works. So, I mean, I would suggest that is a collective challenge for GPs generally, and I know we've had discussions with the Royal College of General Practitioners, as well as what's happening with NIMDRA, and also all their peers working together to really embrace those who have come to us, so that, as the point I think you're getting at, that they commit and remain to serve our community in Northern Ireland.
Peter, I mean, I agree with you. I'm happy. I really welcome people who want to come and live and train and so on. I'd love them to stay and, become those family GPs that are so precious at the minute. It's just trying to understand, do you have an understanding of that? Does the department have an understanding of that?
We're very aware, we know who is coming in, who's accessing the programmes. And there has been maybe a bit of a spike in that in the last couple of years, but that's generally, if you were to look at the GMC statistics to see where people are coming from, joining the register and practicing in the UK in medicine, there's been a really, really large increase from a relatively small country beyond the EU. And so we're part of that trend, but it is absolutely recognised. But we want them to stay. The GPs want them to stay. NIMDRA want to stay. So we're looking at what do we need to do to embrace them, to welcome them, to help them stay.
Even to help them to settle. Yes,
that's right. And another thing we also are very conscious of, though, is that you mentioned about and Phil mentioned his introductory comments about we now have the UU producing graduates from their medical school. We're going to have more people coming out of our local school who we want to encourage into general practice. So there's issues there, and it's been recognised in medical schools in NIMDRA about how our students are really trained and encouraged in terms of being prepared for the GP recruitment process, so that they have a good chance of succeeding if they're in competition with others. But I could also say there are other things potentially afoot which might look at changing that balance in terms of how to better manage at a macro level recruitment at a UK level into medical programmes generally. But that would be something that would be done on a 4-country basis.
Yeah, no, as long as we have, as an HSC, an understanding of what people need to help them to stay, how we can, and that you are addressing those issues. That's
we see that because we've had some experience in the last couple of years in terms of on the nursing side. There was quite an uptick of our international nurses, and quite a very high percentage of them have remained.
Over the last 9 years, 90% are still here who've arrived. So over 1,800, 1,700 are still here, and so they've gone past the indefinite leave to remain. They've applied, make application, and there's costs attached to that, but they want to stay here. They've built a life here, and the kids are at school, and they're into the property market. They've made a life here in the community.
There's learning there we're trying to apply, but obviously there are some different things in GP, and it is very much about making those connections as well. And another thing is really the looking at maybe rebalancing the GP training programme onto more of an integrated model, which gives more experience in general practice and more time in general practice and less in hospitals. And it's really that contact with local communities and with people, which really, I think,
people to feel at home.
It's a support network. If you have the right support network, then it really benefits.
Okay, thank you, Danny.
Thank you, Chair, and thank you for that. Quite a few of the questions that I was planning to ask have already been touched upon, but I do want to develop it on a bit further. First, I'll just declare an interest as a nurse, Band 5 and Band 6, who's worked in the South and Eastern Trust, and I still work there. It's very surprising that pay isn't mentioned in the workforce plan, particularly as you mentioned you've come through and you've settled a couple of quite recent incidents of industrial action. So pay is obviously a very sore point right across various areas in the health service. Why was it not mentioned as much at all in this workforce plan?
Well, I suppose we talk in terms of our workforce strategy and our workforce plan about making HSE an attractive place to work, and we talk about that strategically and generally, which would include pay as well as other issues like pension and all of those other kind of benefits that HSE employment brings that maybe independent sector or different sectors don't bring. So I think it's there, but indirectly. Pay is obviously there's a process around pay and around how we come to a pay award on an annual basis that is probably it sits out with the sort of the workforce strategy, if you know what I mean. It's an annual process, part of public sector pay rounds, etc. So I think that's why it's probably not obliquely or explicitly mentioned in the workforce strategy. But coming back to the pay awards and our approach, we have managed to settle the 24-25 pay awards. Looking ahead to the 25-26, the Minister has given his commitment that, all things being equal, he wants to move much more quickly in terms of implementing pay awards for this year. And you'll appreciate our pay structures and agenda for change, or medical. That's all part of a national process rather than something that's entirely within our gift locally.
No problem. Well, obviously it's a key concern for many workers, and that's the reason they've been driven to industrial action. Nurses twice within the last 5 years. It is a huge concern for many of your healthcare workers who feel that they're not being paid fairly, and certainly I would suggest that it is something that you keep a very, very close eye on. The second question was something Linda had already touched on and the Chair had touched on, was the Pathways to Progress report from the RCN. And you had suggested that the nursing workforce is predominantly in Band 5, and sadly that is the case, but that's the point of the report. The report is suggesting that it shouldn't be. The report is suggesting that too many nurses spend their whole careers at the grades that they qualified at, and that's not comparative with other areas within health. I think midwives, comparison is 13% of midwives are at Band 5, and they progress to Band 6 relatively quickly through Annex 20 of Agenda for Change. This is not available to nursing staff, and the point of the report was that this should be available. And do you have a response to that report, and can you see the benefits to nursing staff? We've talked about problems with recruitment and retention and well-being of staff, even patient safety. We know that in our better staffed wards there are reduced risks to patients. Mortality goes up on poorly staffed wards, length of stay goes up, so we know that there are real impacts on patients because of the nursing shortage on wards. I understand, now I don't know, we were talking about the figures, the RCN figures and the figures of vacancies. The most recent figures I've got, I think, are 1,800 nursing vacancies across Northern Ireland. I think that's December 24. Sorry, yes, December 2024. I don't know if you would be able to verify that. And go ahead.
Where are we? So we have a table. So we've got about nursing. So for registered nursing and midwifery, December 24 vacancies were about 1,200. But when we add in the nursing and midwifery support roles, then it would be about 1,900. So it's about 600 for the nursing support roles, and about 1,200 for the registered nursing roles. Now those figures, we're seeing some improvement there. If we go back even just a couple of years, December 22, we had about 2,200 registered nurse and midwifery vacancies, and that's down to 1,200. So we're making progress, which I suppose is worth highlighting. And of course that 1,800 vacancies across those two subgroups is out of a workforce in that area of what about 22,000. So
that's growing.
Since on a growing workforce, so it's,
the
about 1,800 out of 22,000. So it's less than 10% would be the vacancy rate across those two bands. But again, I think, as we said earlier, the challenges we've identified appears to be more in the support roles at this stage, rather than the registered nursing workforce. Although we do recognise that there are vacancies and challenges in that space and as well. I suppose on the wider point around the band 5 versus band 6, there has been some work ongoing with at a national level, looking at job profiles, etc. of different. I think the plan is to do it across different agenda for change roles, but I think the focus first on the nursing roles, and I think we did commit as part of the pay negotiations last year that we would look at some work considering those outcomes from that national review, that we would commit to looking at some work around looking at how we might rebalance locally between band 5 and band 6. As I said earlier, I think that's really, that's us working collaboratively with the trusts who make these decisions in terms of employment and in terms of what they think they need in terms of delivering a particular service at a particular time.
You mentioned the students. I think it's just over 1,000 are coming out as qualified.
I'm just trying to think now. Is this our last year of our NDNA boost? So there'll be 1,300 graduating this next couple of weeks.
Right.
I would
But
expect.
also there might be some.
But going in then in 25-26, we've got about 1065. Will be going in September.
Do you know how many posts that the trusts are actively recruiting for, full-time contracted posts? Is that something that you have?
That's what that figure is.
Yeah, so that 1241 is the active vacancies that are being currently pursued.
The trust recruiting them as full-time contracted posts?
I would assume so. I don't know if we have that level of detail, but
I don't think you've provided us with those details about the level of numbers of vacancies across the areas.
It's published information on the DOH website. We can share the detailed report. It's a detailed statistical report. I'll just say that and just leave that there.
It relates
if you could even pull out the number of vacancies across each of the areas, I think that's useful information. I'm not saying there isn't other useful information, but
yeah, that's the most recent information of December. I think, is it next week?
Next
week there'll be a new publication next week.
Session for the end of March.
It takes to the end of March. Yeah.
Okay.
We will ensure that that's forwarded to you.
Just can I ask as well, obviously we hear from a lot of different areas in healthcare about people moving down south, whether that's social workers to Tulsa, whether that's contractors that are moving to Sláintecare, nursing staff moving to other countries, even staff moving to the independent sector. What are you doing to combat that? What are you doing to try and entice workers to stay here in the health service?
Well, I think that's part of our focus when we look at when we publish our action plan for the next 3 years in terms of our workforce strategy. Really, retention has been identified as one of the key elements of that. So we have committed to sort of developing a retention plan across each of the professions. So because the issues are different depending on what profession you're talking about. So that's certainly something which we intend to drive forward, working collaboratively with our chief professional officers, so whether that's pharmacy or dentistry or whatever, and working with the trusts. I think when we look at sort of north-south movement, I do think we see a bit more of a trend in, I suppose, what you would call the border trusts, the sort of the western and the southern trust. I think it's more of an issue where people can maybe work cross-border without having to relocate, if that makes sense. So I think yes, I think trusts do a lot of work in terms of trying to retain their own staff, and I think the challenge is it's a very variable picture depending on what profession you're looking at as well. Some professions, I know, for example, when I talk to our chief AHP officer, the professional development opportunities, for example, that are available in HSC, so in the Northern Ireland system as opposed to HSE, she would argue are much better, and therefore people are more willing to work here than the other side of the board. In other areas, and we know, for example, it's been raised with us around some of the challenges around pharmacy in the Western Trust area, which people leaving Western Trust and working in Letterkenny. So there are different challenges. Trusts are doing as much as they can to try and retain staff, and obviously highlight the benefits of HSC employment as opposed to HSE, and we have committed through our strategy to work across the piece to try and develop a retention framework, I suppose we'd call it, for each of the professions to try and address some of those issues. Because while the obvious one around Western and Southern is north-south movement, there is other challenges, could be east-west movement, or a lot of healthcare professionals are very mobile, they've got good skills, so they are internationally mobile professionals. And our job is to try and make HSE as attractive as possible as the place that they want to work in.
Do you see that happening? Do you see the trends dropping, or?
Well, I think when we look at our overall numbers, we've got more people joining than are leaving. Yeah. We've got more people, people who are leaving. I suppose it's one of these. There will always be people who move jurisdictions for career development purposes for whatever reason. Might be family reasons. There's reasons why people go, and there's reasons why people come, and there's reasons why people stay. But I think when we look at our overall figures, our churn rates in terms of people who were employed in the service 1 year ago and are still employed in the service are pretty good. And again, they're excess of 90% of people who were here last year are still here. Our leavers numbers are sort of pretty stable, and our incoming numbers, our joiners numbers are going up. So we're having this net position where we're able to say the number of people employed in HSE is growing year on year.
We can see that as well for example, nursing. You mentioned the NMC stats as well. They have it by each country, and it's growing. It has consistently in Northern Ireland and England. Interestingly, Scotland is the area and the one country in the UK that's having the greatest challenge in respect of retaining its nurses. But we have had a continuous pattern of growth and stability, which is good.
Thank you.
Could I ask just a very quick question on the back of what Danny is touching upon here? Just outside of those trusts that are closest to the border, what sectors within HSC then would be the most challenging to retain? And I'm thinking about within A&Es. I note earlier in this week I was looking at the statistics of hospital or sort of ED waiting times, whereby some were sitting at 600 minutes. I think Craigavon was touching upon 720 minutes on Monday or Tuesday this week. And we all know that whenever the high pressures that is happening within EDs are highlighted on social media, I'm sure that must be something that distracts from anybody wanting to take up a career within HSC. So I'm wondering, is EDs, accident emergencies, are those the sectors, or is that where pressure is the greatest to try to retain staff?
I think it's difficult to be specific. We're looking at a very strategic, very general picture across the piece, and we're looking at numbers, and there will be challenges in particular services or particular sectors that might drive people to take particular decisions about relocating or whatever. EDs is an interesting one where actually I think we're seeing, just in recent weeks, we're seeing sort of a bit of a turnaround. There's been a Minister met with the Royal College of Emergency Medicine a number of months ago, and they highlighted a challenge that there were, I think, over 26 individuals who were on that NIMDA training programme who were coming to the end of their training. They were going to be they were going to become consultants. I think CCT, they were going to become consultants at the end of their training. And he asked then on the back of that the HSC collectively work together to ensure that we recruited these people as they came to the end of their programme. And very successfully we've managed to recruit them all.
Yep.
And so there's very positive news already emerging.
There's a danger that it could have been lost to have to look at jobs elsewhere in the UK.
Could have been UK, could have been Ireland, could have been internationally. So again, we've made really sort of proactive moves, I suppose, is what you would say, to try and recruit those individuals, and say we've had some success. Now they're relatively recently. I don't think all of them are actually in service yet, but they're going to be joining services. But we're hearing some positive stories about the impact that has on rotas, about how many times existing emergency consultants are having to do cover at weekends. So it's creating a better atmosphere for those individuals within that emergency department.
I could say it does reflect that we had a few years ago some workforce planning done in this area, and we recognised the need to significantly grow and manage to invest in growing the workforce, and this is actually them following
the
through.
Workings of that, yeah. So
that's an example when it does work the way it should do.
But I probably shouldn't say this, but for every positive story like that, we know there will be another service somewhere that is, that there's a high level of vacancies, and people will be actively thinking about taking decisions that might take.
On that positive note, Chair.
Okay, thank you, gentlemen and ladies. Thank you very much. That was useful. See you in 6 months. Looking forward to it already. Okay, so we're going to basically just jump across everything to item number 11, correspondence. So can I refer members to the correspondence list, page 312, and refer to page 314, which contains the... I'm just picking out items here. So 314 contains the departmental correspondence with Parents for Pegs in respect of the autistic children who require surgery at the Belfast Children's Hospital. So the correspondence outlines the pre-op measures taken by the Trust and the range of autism training which is available to staff. I don't know if members have any comments on it. Are people content to note? Okay. Improving health within the criminal justice systems at page 316 contains a joint progress report by Department of Health and Department of Justice in respect of improving health within the criminal justice system. So, any comments, Linda? No? Okay. So then, our inquiry palliative care, page 366, that's a departmental response to our queries arising from evidence sessions on the palliative care inquiry. So we're going to be considering this response and all the other relevant information in the closed session in the weeks ahead. So unless anybody has any comments to make now? None? Okay. So HPV testing at the Belfast Trust, that's at page 441. It provides a response to the additional queries the committee had in respect of HPV testing at the Belfast Trust. So this response includes an explanation of some of the process for awarding of the screening contract, which is precluded by an invitation for expression of interest. So the department is advised that the Belfast Trust scored lower in the UCAS accreditation element of the application, but its scores in other areas exceeded the other applications overall. So Dan, you want to comment on that?
No, I just want to sort of, I was wondering whether it would be worthwhile having the Trust and the Public Health Agency, just so that we can ask them for a very short, sharp period, some questions around the HPV testing. They say it is getting better. In other words, that the waiting times for results, etc., is getting better. But there is some query over where the testing is actually being done within the Trust and so on. And I think this is a fairly huge multi-million-pound contract that they have, and it may be worthwhile having them here to have a conversation around it. That's all.
We have a briefing on the cytology, and it might fit in with that, as opposed to a separate briefing.
No, it would. That's fine.
Okay,
totally
perfect.
fine. Yeah, it would.
Okay, so that's coming up soon.
Yeah.
We've
Well,
requested
that's completely fine.
from the department following the
I
two.
should have read the forward work plan.
No, so
yeah.
it may not be in that one. It's in the tabled one.
Thank you.
The department have indicated that they want to brief on the review of on the two reviews that took place.
Yes, but when we're doing it, then can we make
Yep.
sure that the relevant people would be here to
And
answer
connect that through
questions
to it as well,
on,
so we
on
can.
that, so we can have it all together?
Yeah.
That's dead on. Dead on. Thank you.
Okay, governance arrangements for new build at Belfast Children's Hospital. So can I refer members to page 457, which contains a departmental response to committee queries arising from evidence sessions on the 10th of April. Are members content? Dan, you want to come on this?
Yeah, no, well, I mean, there's nothing new in the governance arrangements. We've kind of heard that all before. But it is quite significant that this letter starts out with the absolutely appalling situation that there is still no timeline for the operational opening of the new maternity hospital. This maternity hospital was handed over a year ago, in fact, for probably 14 or 15 months ago, and we still have no timeline and information in this in relation to that handover. And I do suggest it's time we heard from the Trust in relation to it.
Okay, I mean, I don't think anybody could disagree with that. I know when we met them, when they talked about the three options, and
yes.
The fact that we haven't heard anything is probably, well, I'm not going to say anything, but I can make my own assumptions. So I don't know if you're making any suggestions or.
Well, I just think we should either they come here and talk to us and tell us specifically. I think it is worthwhile pursuing with them. By now, they told us that they would have a way forward. Yeah. I'm right in that, aren't I?
Yeah.
Yeah.
They did.
They told us that they would
yeah.
have a way forward in April sometime. We haven't heard the way forward, and I just think that it would be really useful to pick that up
back to the
again.
department or the Trust and explore with them?
We followed up again just in the last couple of days, so it is asking for the information again on the basis of what we were told would happen, and we're waiting a response on that. So we are.
So maybe we could wait till
Depending
next
on
week.
what the response is, then can we come back? Because I just think that is an entirely unsatisfactory situation.
Absolutely. Linda, your hand's raised.
Yeah, it was actually on the previous item. Sorry, and I think actually Deanna's covered it, just in ensuring that the right people are in the room. So I would suggest even making sure that they know those questions that we're asking the answers to. They know them anyway. We've written to them repeatedly. So I think that we need to just ensure that the right people are in the room, whoever that is, to answer all of those questions in relation to both cytology and all the issues around the review.
Okay, Danny, you were looking to come in.
Sorry, it was just about a previous item of correspondence, if that's all right.
We'll go through these ones, Danny, and then I'll bring you in. Is that all right? So, Emer's Wish. So there's a request for a meeting. That's at page 491, which is a request for from Emer's Wish, not-for-profit registered charity, requesting an informal meeting with the committee as part of their launch of the Families United Against Blood Cancer campaign. So, are members content that we organise an informal meeting? Okay. Parkinson's UK, so that's page 499. It's a request from Parkinson's UK to meet with the committee. So I'm going to suggest that as the department is presently consulting on regional review of neurology services, that the committee may wish to wait to the outcome of that consultation and then deal with the request for a meeting with them. We're happy enough with that, just so there's something more to discuss once that consultation.
When is the outcome due of the review?
This is a good question.
Wouldn't like to
consultation's
put
due to
it off if it was a very long time away.
No,
I think the consultation's due to close in August.
Oh, right,
off the top of my head.
Oh, that's a very long time away.
So it is.
Not
We could ask for a copy of their response to the consultation. In the meantime,
From Parkinson's UK's
Yeah.
response. Okay. Members, do you want to do that, or do you want to go and grant informal meeting? Maybe we should go back to them and suggest that would it be better waiting until after this?
Yeah, maybe talk to them just.
Yeah, it's out for consultation until the 6th of August.
So we'll not know the results of that consultation at the end of the year.
Fair enough. No, I'm happy enough.
So
to
I
organise an
don't
informal
think
meeting.
it would be tenable not to.
Okay. Just organise an informal meeting with them?
Yeah.
Okay. So we've dealt with the issue of the GPs. And Dana, you want to come in on another item?
Yeah, just on 11.6 on the letter from Alliance for Choice, just about a healthcare organisation in Belfast. I think the suggested action is that we have an informal meeting with them, and certainly I'm very supportive of that. But I think we should be writing to RQAA and the department about this as well, just to see if they would have a look at these allegations. They're very serious, and see if there's anything that they would respond to in that.
Yep.
Okay.
Yep. I see also in the correspondence, the Department of Health reply, read the role and the remit of the RQA, just when you mention them, so they're basically saying they're not planning to give any more money despite expanding their remit. So I know from our meeting with them, that's a disappointing response. Okay, so are members content then with the actions we've agreed, and then the further actions as set out in the table? Dan?
Can I just ask about the correspondence from the ladies with letters? There are quite specific issues in that correspondence, and I was wondering, would it be worthwhile forwarding it on to the Minister for a response?
Absolutely.
So that, you know, we have something formal to go back with. I think that would be useful.
Yep. Very good suggestion. Okay, members, moving on, and item number 12, forward work programme. So page 59 of table papers, we have the draft forward work programme. So next week we are visiting Common Youth in Belfast, Moraine Street, 11 AM next Thursday for anybody that's available. Our meeting will then take place at 2 PM here in Parliament Buildings. That informal meeting then we have with the Pharmaceutical Society has been arranged for Tuesday the 27th of May at 1 PM, room 21. Lunch will be provided and an invite will issue from the committee office tomorrow. Again, just to remind you, 12th of June the committee will hold a stakeholder event which will inform a very significant part of our inquiry. So we're meeting with people with lived experience, so I mean that it is obviously very important that we all can make ourselves available for that. So are members content to note those briefings as set out in the forward work programme?
Yeah.
Okay. Any other business? None. Date, time? Oh, Linda, sorry.
It's all right. I had met with some of the people involved with the Reimagine Children's Service Collective, and I think it would be useful for the committee to do an informal briefing with them, just to have a conversation with them around, I mean, Ray Jones' report and what has, or more importantly, what has not been done since that report was published. So I think we just need it as a committee, get an understanding, a sense of what's happening around that.
Okay, agreement here. Okay, so thank you, Linda. Date, time, meeting next, committee meeting next Thursday, 22nd of May, room 29, 12 o'clock, 2 PM.
Committee room 29, sound. Committee room 29, sound. Committee room 29, sound.